dignitaries, and delegates, thank you for joining SHIELD. I'm Dr. Maunika, Regional Medical Advisor from SHIELD Healthcare. It's my privilege to welcome all of you for a wonderful series, Trending Ask series, which is organized by AGOG, Academy of Global Obstetrics and Gynecology on SHIELD Connect. So in this task series, we'll be covering topic A to Z. And today, episode P will be covering PPH and placental disorder. So before we start the session, let me show the short introductory video of AGOG.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
And with that, let me introduce our coordinators. I welcome Dr. Shreya Prabhu ma'am. She's an MBBS, DGO, DNB, MNAMS, FICOG, obstetrician and gynecology at Mukund Hospital, Surya Hospital, L&T Healthcare Center, Mumbai, Nirali AM Nayak Hospital. I welcome you, ma'am, and I welcome Dr. Anusha Devalle ma'am, MSK KMH Mumbai, DNB OBGY, Assistant Professor, People's College of Medical Sciences, Bhopal. I welcome you both and I hand of the session to you.
Hello, good evening, everyone, all the respected dignitaries, faculties. Today, welcome to the Trending Ask series A to Z, and today's episode P, and it is on postpartum hemorrhage and placental disorders. So PPH is every obstetrician's nightmare, and there have been evolving sciences around it. And shall be dealing with these topics in detail today in our interactive session. Let me welcome first our conveners for this program, Dr. Komal Chavan Madam and Dr. Niranjan Chavan Sir. Dr. Komal Chavan Madam needs no introduction. She is the Medical Director of Chavan Maternity and Nursing Home, Senior Consultant at VN Desai Hospital, Chairperson Foxy Medical Disorders in Pregnancy Committee till present. She is a Chairperson of AMOX Family Welfare and MTP Committee, Joint Secretary of ISOPAB. She has received multiple awards.
Thank you. Yes, thank you. Go ahead.
Welcome, Madam. Welcome. We welcome Dr. Niranjan Chavan, sir. He is Professor and Unit Chief at Sion Hospital, Joint Treasurer of Foxy, President of Mumbai Obs-Gynae Society. He is member of Oncology Committee, CEFOG, Editor-in-Chief of many journals. He is Joint Secretary of Association of Fellow Gynecologists, Mumbai. He has published in multiple national and international journals. He has received many awards. Welcome, sir.
Yeah, he's just joining. Okay. So thank you so much, Anusha and Shreya, our coordinators for today's program. And I welcome all of you for this Trending Ask the Expert series. And today's episode is episode P. And when we talk about P, we think about placenta in obstetrics and the complications associated with it, the most dreadful being the PPH. So this is a focused episode on placenta and PPH. And I'm so honored that I have presence of Dr. Usha Sharma Madam as the chief guest and Dr. Krishnendu Gupta as the guest of honor. The speakers, Dr. Sheila Mane, Dr. Shashi Kabra, they will be giving the insight of PPH And we have again a case-based panel discussion thinking about the placental disorders, which was the idea behind, because it is becoming very common that every time we encounter so many problems in our obstetric practice with the placenta being abnormal, be it an abruption or be it placenta previa or accreta or a PPH. So that is the idea behind the entire discussion, and I'm so happy that all the faculties have joined. I can see Dr. Achala Bhatta also joined early. So welcome, Dr. Achala Bhatta, Dr. Lata. Thank you so much. And now I will formally introduce Usha Sharma Madam. I know Usha Sharma Madam is a pride of North of India. So I think we all know Madam for her magnanimity, the way she has done the conference of ISOPAR. I think Meerut is known for Usha Sharma Madam, and she is always so generous and kind enough whenever we meet her. And she has also got the most coveted award, that is Padma
It's all
Shri.
right, Komal.
Yes, Padma Shri. So it is my real honor that, Madam, you are there to bless us.
Thank you.
And,
Thank you.
yeah, over to you, Madam.
Thank you so much, Komal, convener of the program today. My dear dynamic, I always say she's such a charming and loving and affectionate Dr. Komal Chavan and Niranjan Chavan. Halaki, I always say that I am more fond of Komal Chavan than Niranjan Chavan. He may be feeling sometimes bad, but this is my कहते ना दिल से निकली हुई आवाज है, which I always say. And coordinators, we have Anusha and Shreya with us today. And then our guest of honor, a very loving, affectionate, knowledgeable, whom I know for a long time, Dr. Krishnendu Gupta. Then our worthy speakers, I always say Sheila Mane as a PPH lady. And she is a lady who lit the lamp of PPH intervention in India. And really, I say, Sheila, your every time session of PPH intervention is an excellent thing, and we always love to have it repeated every time in every conference. And then another speaker, Dr. Shashi Kabra, all of us know that she is a very, very nice orator, and she is also very knowledgeable. Then we know that today the panel will be moderated by the star couple, Komal Chavan and the Niranjan Chavan, and all the worthy panelists as well as chairpersons, the obstetricians who have logged in for this webinar, and all the representatives from Shield Connect. It really gives me a great pleasure to be with you all this evening in this series of A to Z, where we discuss various subjects in different series. And today, as you all know, that we are going to discuss PPH intervention as well as placental disorders. Both the subjects are very, very important and are really very fruitful in our day-to-day practice. We all know that PPH is the leading cause of maternal mortality, not only in our state, but the whole India. The unpredictable as well as the catastrophic, it is catastrophic for the patients and very, very shattering for the treating doctor. And so it is always it needed that we all are prepared beforehand so that we can find out or we can predict the complications which may happen and can manage them in the first golden hour. And this is only the key of success of the management of PPH. You know, all of us know that we have to be prepared all the time, but unfortunately, it's not like this with every obstetrician. It is easier said than done. And so I will request everyone to be very, very careful, to be prepared, because as we know, there should be facility readiness, there should be supply chain of all the drugs, there should be development of good referrals where you can refer the case, then communication network integration, and there are many other guidelines which are being given by the FIGO. and that we should take care of, and every one of us should ensure that we are working as per the guidelines of FIGO. All of us know that placenta is a very vital organ of pregnancy, and actually it is the tree of life, and as well as the proper placental development under a healthy maternal environment is needed for the essential and good pregnancy outcome. And all of us know this also, that abnormal placentation has been the basis of various diseases like PIH, diabetes mellitus, as well as placental accretal disorders. And so it's very important for all of us to know about each and every step of PPH intervention as well as placental disorder. And as we know that the Niranjan and Komal are moderating a panel on placental disorder, and I think it will be a great highlight of today's program. And I'm sure that the deliberations of this program will go a long way in updating the knowledge of each one of us. I wish this program a great success, and thank you very much, Komal, for making me a part of such a prestigious program. And I will like to wish you all the best for happy learning today, and wish you all a very healthy, happy, and a bright future. Thank you very much once again. I wish this program a great success, and I am sure that every one of you will go as an expert in PPH intervention as well as managing placental disorders. Thank you very much once again, Komal.
Thank you so much, madam, for your lovely words, your pearls of wisdom, and your message and your wishes. We are really honored by your presence. And now I call upon our guest of honor, Dr. Krishnendu Gupta. We all know Krishnendu sir is the most learned person. You know, when we want to talk something or tell, I think we really love hearing his talks. And he is such a versatile and gives talks in such depth. So I am so happy that whenever I call Krishnendu sir, he's so meticulous and well planned and well read and well versed person. May I have the formal CV?
Really not required, Komal. You've said it all. Thank you so much. I feel so embarrassed.
I know he's from Kolkata. I can talk about you without CV also. I know you're the chair of the ICOG. You have done such wonders, and currently a professor and head of unit at Vivekananda Institute of Medical Science, Kolkata. And he is currently the FOXY representative to AOFOG. And that is very important. And I think he is the Deputy Secretary General of AOFOG right now. Yes. Sorry for that. And he is the chair of the Environmental Committee of FIGO. So I think, sir, over to you. You can please address all the audience and please bless us.
Always there. Thank you so much, Komal, for this opportunity. Respected Madam Usha Sharma, it's hearing you itself is an education. I mean, believe me, if anybody would have said, give the PPH and placental disorders in a nutshell, I think you have done that so beautifully. And of course, this entire, I should say, this team of Komal, Niranjan, and their academic team is really doing wonders for the through the webinars, disseminating knowledge. You have Dr. Sheila Mane, who's, as you said very correctly, done so much of work with PPH all her life. And if such people give presentations in these webinars, it's an education for everybody. And thank you very much. I will really not take more time than this. You're doing a great job, Komal. We want you to grow higher and higher in FOXY, and that's what we are all looking for. And really
wish her all the best for her elections.
Absolutely. And
we will like to see you as vice president.
hearty congratulations for this wonderful program. And to all the speakers, thank you for joining and making. And I'm sure this webinar is going to be a super success, like it's all been. I mean, this is going on for a while now, and we have such illustrious people here. It'll make it very great. So great topics. And I think it's going to be a great evening. Thank you so much, Komal. Again, it's a pleasure. and to be here. And thank you, madam, for those lovely words. It really means a lot to me, Ma'am Usha. Thank you. Thank you.
Thank you so much, Krishnendu sir, and thank you, Usha Sharma madam, both for your blessings and your support. And I'm really honored today because we have rightly said the PPH lady, Dr. Sheila Mane here. And when I think of PPH and the authority and the way, I think she must have saved countless of lives, by teaching other people to save lives. So I think that is the best work which she's doing. And I'm so happy that she's here and we'll start her talk. I'm eagerly waiting to hear. So over to you, Dr. Anusha. You can call the chairpersons and start the academic session. Thank you, Chief Guest, Dr. Usha Sharma Madam and Dr. Krishnendu sir. Thank you so much.
Very sorry, Komal. After 15 minutes, I will have to go. As you know, I have some other webinar also.
Sure, madam. Sure. Thank you so much.
I think you will have recording of this afterwards.
Of course. We have a recording which is also viewed.
Thank you.
We get a 500, 600 plus
Let
views.
Sheila start.
Thank you, madam. Madam Usha, thank you.
अभी
आपसे मिलकर आई हूँ और आपकी एनर्जी देख के मैं तो इतनी इम्प्रेस हो गई हूँ कि that day the way you were working at Meerut for that ISOCOP conference, hats off to you, madam. Namaskar.
Thank you, ma'am. Thank you, sir, for the lovely words. Let us start with the first session today on PPH current trends in preparedness and management. Can I have the CV slides, please? I welcome Dr. Usha Goenka, madam. She is consultant obstetrician and gynecologist and head of department at Ann Hospital, Kanpur. She is president Kanpur Obs Gynae Society. She is life member of FOGS since 1982, life member of PAT, vice president of OG 2019 to 21. She has received special education under Dr. B.N. Chakravarti, sir, and postgraduate certificate in HAM, past distance learning program in medical and ethics, attended World Conference on Breast Pathology. We welcome you, madam. I welcome Dr. Priyankul Roy, sir. He is assistant professor at Lord Buddha Koshi Medical College and Infertility and Gynae Endoscopy Center and Roy's Clinic and Ramakrishna IVF Center, Siliguri. He is chairperson, Public Awareness Committee, FOXY, vice president, WATOG, FIGO, and MCM, Contraception Committee, FIGO, member of Scientific Program Committee, FIGO, World Congress. And he has received multiple awards, notably Korean Award in 2017 and recently Dr. Kumud Tamaskar Research Award. We welcome you, sir.
Thank you so much, ma'am.
Yeah. Welcome, Priyankur. Yeah, you can go ahead and introduce.
Yeah, thank you, Komal, ma'am. So it gives me immense pleasure to be part of this wonderful webinar today, AG-OG. And it's a pleasure to be, of course, hearing our chief guest and guest of honor, Usha Sharma ma'am and Krishnendu sir. And also I would like to thank Komal ma'am and Niranjan Chauhan sir for giving me this opportunity today. So who better to listen to PPH than, of course, as we all know her as the PPH lady of India, Dr. Sheila Mane ma'am. And she is, of course, we all know her as a teacher. She has been teaching DNB and has a number of students under her career whom she has taught, and she has given her experience and teaching as well. She is ICOG Governing Council member and also currently elected as one of the office bearers of ICOG as well. Ma'am is her area of expertise, of course, is high risk pregnancy, fetal medicine, and she has had her fellowship and also as a member of various other organizations, including AGOI, FOXY, IMA, and of course IMS as well. So it's a pleasure, ma'am, that you're here with us, and we're looking forward to listening to you on the topic of current trends in preparedness and management. So over to you, ma'am. Thank you so much.
Thank you.
And also, of course, if I don't forget, she has been the organizing team of various conferences, and I was lucky enough to be under her leadership for one of the conferences, the South Zone UVA FOXY, when I was doing my post-graduation. So welcome, ma'am, once more. And Komal, ma'am, wish you all the very best for your future endeavors. I'm sure we'll see you in the office bearers post very soon after this election as a vice president.
Thank you so much, Priyankur. Over to you, Dr. Sheila Mane. And I want to add that she has made India proud. You know, FIGO is now going to adapt the PPH, whatever the guidelines, and the way the posters which she has made, they are displayed all over the country of Dr. Sheila Mane. So it's really pride, and there was a big meeting also in FIGO on PPH, which she has led that meeting. So we really have an authority over the subject. So over to you, Dr. Sheila Mane.
Thank you all. And I must tell you, I had an opportunity to attend the Global Summit of WHO in Dubai recently. And this meeting was called for a call of action. And this call of action for PPH, because we have still not given so much of importance to this problem, even though we say that we are losing maximum mothers due to postpartum hemorrhage. So actually now WHO wants us to have a PPH day. And shortly I will come up with that I would like each and every society to have a PPH day every month, so that not only we are making aware of our obstetricians, but also the public. Because anemia plays a very important role in PPH, and indirectly it causes responsible for postpartum hemorrhage. So let us have a PPH day. See, we have controlled tuberculosis, we have controlled HIV/AIDS, we have working towards control of malaria, but we never thought that we have to work like that for postpartum hemorrhage. And that is why there was a call for action by WHO, and the roadmap is made from 2020-23 to 2030. We have to see that the burden of postpartum hemorrhage is reduced. So, and we have to work nationally and globally with collaboration to see to it that the burden is reduced. Because, you know, at the end of the day, it is the woman's life, the mother's life, which is so important. And happy that God has given me the opportunity to work for this cause. All are here stalwarts, Dr. Achala, Dr. Shashi, everybody is going to talk about it and going to share their knowledge. And thank you for giving me opportunity, Dr. Komal. And thank all my seniors for their blessings. I will share my presentation. Sorry. कुछ तो गड़बड़ हो रही है. Can you see it? No. Is it
share again?
No.
Now, after I share screen, I have to share, click on that share button, no, blue color.
Yes.
Yeah. And after that?
Yes, now we can see your screen, but your presentation is not open, madam. So
that is why I am also facing the same problem. Why?
Click on the PPT below, in the task panel below. You can see the PPT
stop share,
PowerPoint icon.
मैडम पहले पीपीटी खोल लो ना स्क्रीन पे.
हाँ, खोल दिया.
हाँ, अभी शेयर करो.
So उसको मिनिमाइज कर दिया, उसको मिनिमाइज किया.
हाँ, now you share screen and click on the PPT.
नहीं आ रहा है, पता नहीं क्यों आज मुझे इतना प्रॉब्लम आ रहा है, पता नहीं. Why I am facing
this problem? Is it on the desktop, madam? We can open like that also.
Yes,
there on the desktop.
Yeah, then madam just share, na? We can see your desktop.
या तुम्हें भेज दे.
हाँ, we can
अभी दिख रहा है?
हाँ, दिख रहा है.
Yes.
Yeah, okay.
Yes. Just slideshow and then it is good.
Yeah, I'll do that.
I'll make it full screen, please, ma'am.
I'll do the slideshow. Is it okay now?
Yes.
Absolutely, madam.
Yeah, thank you. So prevention and preparedness, and as madam said, you know, every day we learn, you know, every day, every case will also teach us. So as I said, it affects so many women and it is the leading cause of MMR. And for every case, there are 10 near misses and which should not be forgotten. So we have to improve the clinical skills and knowledge of the risk factors of PPH because they are instrumental in preventing the maternal morbidity and mortality. So we have to look at the preventing factors, like which are the preventing factors. Now, there is a goal to reduce the burden and the maternal mortality to less than 70 per 1 lakh live births by 2030. Now, what are the common preventable errors? Under recognition of blood loss. And recently, all of us are aware that there was an e-motive study. That is, they have given so much of importance in that study to estimation of blood loss, because unless and until our health workers are trained for the estimation of blood loss, we will be always diagnosing postpartum hemorrhage late. Okay. And E motive stands for you have to explore. So first you do massage. M is for massage. O is for oxytocin. T is for tranexamic. IV is for IV fluids. And E is again, you are going to explore. So again, oxytocin and tranexamics are going to play a big role in prevention and treatment of PPH. So under recognition of blood loss, lack of appropriate attention to clinical signs of hemorrhage and associated hypovolemia, failure to act decisively with life-saving interventions, and failure to restore the blood volume in a timely manner. Now, definitions, all of us, we know that 500 ml for the vaginal delivery, 1000 for the cesarean section. And again, we can divide it into minor and major, moderate and severe. Minor is 500 to 1000 ml. Major is more than 1000 ml. Again, major can be divided into moderate 1000 to 2000 ml, and severe is more than 2000 ml. And secondary PPH is after 24 hours up to 6 weeks postpartum. But for clinical purpose, any blood loss that has the potential to produce hemodynamic instability should be considered as postpartum hemorrhage is the new definition. And we also have massive obstetric hemorrhage. Now, massive obstetric hemorrhage is variably defined as blood loss from uterus or genital tract of more than 1500 ml, or a rate of blood loss of more than 50% of blood volume loss within 3 hours, or decrease in hemoglobin of more than 4 grams per deciliter, or acute loss requiring transfusion of more than 4 units of PRBC, or any hemorrhage associated with hemodynamic instability. We are all aware of these 4 T's. Again, atony commonest. Next comes the retained placenta, then the trauma, and then the thrombin. So these are the causes divided according to the cause. Now we know that the commonest for the atony are the previous history of PPH, multifetal pregnancy, grand multiparity, fetal macrosomia, polyhydramnias, failure to progress in second stage of labor, prolonged third stage of labor, fibroids, and general anesthesia. And anemia is added there. Very important. I will come to that why anemia causes PPH. Trauma, operative deliveries, perineal lacerations, episiotomy, tissue retained placenta, placenta accreta. Now this placenta accreta is really becoming a nightmare for us. Thrombin, again, the causes of DIC like preeclampsia, there could be HELLP syndrome, bleeding disorders, sepsis, or if the patient is on certain drugs. Now, there are 3 main broad areas in which the outcome from PPH may be improved. That is prevention, treatment, and rescue. Now, prevention covers antenatal strategies, that is AMTSL, and treatments for retained placenta. PPH treatment covers both medical and surgical treatment. And PPH rescue therapies include IV fluids, blood transfusion, coagulation correction, and supportive care such as compression garments. So all of us, we know that this is the histogram of blood loss at delivery, showing the death zone at a loss of over 40% of blood volume, and the 3 strategies for intervention. And this data was adapted from HOS 58 with corrections to the published data. So we know that if the woman has lost more than 40%, definitely she is near the death zone. So one should start with prevention. After diagnosis, when the blood loss is more than 500, treatment and rescue should happen before the patient goes into a class 4 hemorrhage. Now coming to the prediction. Previous PPH or retained placenta, now maternal anemia. I want all of us to learn this, that so many days we are saying anemia causes PPH, anemia. Why anemia causes PPH? Why it causes atony? 1, the anemic patient, the blood is more viscous because there are less RBCs. So more viscous bloods, more bleeding. The fibrinolytic activity of the anemic patients as the RBCs are less is lesser. So the clots will get dissolved early. Third, the normal vessel has a lamellar flow where the platelets are at the periphery. But here, because of the increased viscosity, it is lost. And if there is any bleeding, these platelets will not go and adhere there. 3. Fourth is again, that is there is a iron deficiency. Now, iron deficiency, every muscle cell will have a less iron. Equally, even the uterine muscle will have less iron. So, these are the causes which can lead to postpartum hemorrhage. So, it is so important for us to see to it. And last is, the anemic women has an increased pulse rate. That is why there is an increased stroke volume. And that naturally, if there is an increased stroke volume, the patient, if she starts bleeding, as she has tachycardia, she will bleed more. And I have understood this after attending this global summit, and I realized that how important it is to correct anemia in every antenatal patient. If we correct anemia, whatever we say that anemia is responsible, many cases we can prevent postpartum hemorrhage. Maternal age about 35 years or more, body mass index more than 35 kg per square meter, grand multi, APH, over distension we already discussed. So these are the antenatal risk factors. Risk factors in labor are equally important. So we are looking at prevention. If the patient is on induction of labor, if there is a prolonged first, second, or third stage, secondary arrest of labor in multigravidas, use of oxytocin, precipitate labor, operative delivery, or cesarean. Because in cesarean section, the percentage is higher for PPH than the vaginal delivery. If it is 2 to 4% for vaginal delivery, it is 4 to 6% PPH in cesarean. So the prevention, a patient safety bundle is required, is a set of straightforward evidence-based recommendations for practice and care processes known to improve the outcomes. So the consensus bundle on obstetric hemorrhage is organized into 4 action domains: readiness, recognition and prevention, response, very important, and reporting and system learning. And there are 13 key elements within these 4 action domains. Readiness, yes, every unit. Hemorrhage cart with supply checklist, instruction cards for even how to put the balloon and compression stitches. Immediate access to hemorrhage in medications. And that's what even Komal was mentioning, that we came out with the kit, which is there even in the Foxy website still. The simple kit, you know, the PPH kit. Establish a response team. Who to call when help is needed. Like you should have a immediate access to blood bank. You may need an oncosurgeon, other support and tertiary services. Establish massive and emergency release transfusion protocols. Like if you have a busy unit, you should have a type O negative blood, or even sometimes you can give uncross-matched blood if the patient is in class 4 hemorrhage. Unit education on protocols, unit-based drills with post-drill debrief to know what went right and what went wrong. So readiness means we should be ready with all this. Recognition and prevention for every patient. Assessment of hemorrhage risk, we discussed prenatal on admission. Measurement of cumulative blood loss, either formal or quantitative, and active management of third stage of labor. So 9th and 10th, response, every hemorrhage. There should be a unit standard stage-based obstetric hemorrhage plan with checklist, support program for patients, families, and staff, which is very important. Reporting and system learning every unit. You have to establish a culture of hurdles for high-risk patients and post-event briefs, multidisciplinary review of serious hemorrhages for system issues, and monitor outcomes and process metrics in perinatal quality improvement. Suppose we had 3 cases of PPH, we must know whether it was a referred, it was unbooked, it was anemia, it was prolonged labor, or it was no drugs availability, or it was some complication. So then we will know where to act. Readiness, as we said, that includes 5 areas of focus to address every facility to prevent delays and prepare for the optimal management of obstetric hemorrhage. Readiness aims at improving even interdepartmental coordination. You may need investigations, blood bank, and help of others. So all of us are aware of the medication kit. I don't think I have to. The only addition to this kit is tranexamic acid. And after women trial, all of us know that tranexamic acid should be there in the hemorrhage medication kit, and it has to be given within 3 hours. If it is given, it has the benefit. Then for surgery, trauma could be there. So vaginal retractors, speculums, long instruments, needle holders, scissors, Kelly's clamp. sponge holders, intrauterine balloon. You need big curettes, a bright task light, and procedural instructions also. Cesarean, laparotomy tray should be ready with all the suture materials available. And also there should be an instruction that how they can put the compression sutures. Even we can use balloon there also, and procedural instructions. And you have to establish a response team. Determine who will be the part of the COVER response team. I always say that we should have a H code in labor room because, you know, we deal with so much of H. We have hemorrhage, we have hypertension, we have anemia, that is less hemoglobin. And so you have to see to it that you have a code system. Primary maternity care provider and nurse and clinicians from anesthesiology, transfusion service, pharmacy, advanced gynecological surgery, critical care medicine, the main operating room, the interventional radiology, and additional nursing resources. Use readily available phone or pager numbers or a rapid response or code system in case of an emergency. It should be checked every day whether the code blue system is working or not. Recently, it happened that it didn't work in our hospital. And luckily, I was in OT, so I could bring the anesthetist with me when the patient was gone. So your response team have to be always ready. And you have to establish massive and emergency release transfusion protocols, because massive transfusion protocol facilitates rapid dispensing of the red blood cells, plasma, and platelets in a predefined ratio intended to preclude the development of a dilutional coagulopathy, because that can result if a significant percent of patient's blood volume is replaced with large quantities of crystallites, colloids, or RBCs. So what we learn now is not to pop the clot. We don't have to give unnecessarily crystallites, but for that your blood bank should be ready. You should get all the blood and blood products immediately or within 10 to 30 minutes. As volume is replaced, attention must be paid to coagulation parameters, platelet count, and metabolic status. Now, there are no national guidelines for activating the massive transfusion protocol. Even we learned during the WHO summit that very few like RCOG and ACOG have, and still we do not have. Now, the criteria are varied and include when patient is actively bleeding, which patients requires massive transfusion protocol when the systolic blood pressure is less than 90 millimeters of mercury, pH is less than 7.1, temperature below, hypothermia, hypovolemia, INR more than 2, that is coagulopathy. This triad is very bad. That means your patient is going into acidosis. And platelet count is also low, less than 50,000 per cubic millimeter. In this situation, you have to tell your blood bank to issue 6 units of PRBC, 6 units of FFP, and 6 units of platelets, and 10 units of cryoprecipitate, because the level of fibrinogen will be very high in cryoprecipitate. Now we have the fibrinogen concentrate, which is available in India, but all of us should be aware that it is available. I know it is expensive, but if you have the facility and if you can afford, and all the busy units must have stored this. So drills, all of us we know. A drill refers to a clear and logical set of steps involved in the patient's management. All team members are familiarized with the entire safety bundle and new management plan. Participating members are assigned tasks and responsibilities necessary to run the drills, and there should be a post-drill debriefing. And drill may be combined with practicing infrequently used hemorrhage technical skills like placing a tamponade balloon or a compressing suture using simple aids. Coming to recognition, assessment of hemorrhage risk. Identification of risk helps to improve readiness. Allow increased surveillance of early recognition. I talked about emotive. Increase the use of preventive measures and prepare the team to initiate an early aggressive response to bleeding. I always say when you receive the patient, patient should come directly to labor room. We have seen all ortho emergencies, cardiac emergencies. The team will rush to resuscitate the patient inside the ambulance. But is that happening for obstetric patient? We have to sensitize our emergency people that as soon as you receive the patient, even they should be trained. So risk assessment should be considered at multiple time points during patient's care, antenatal, on admission to labor, intranatal, during delivery and after the delivery, and even late in labor, because first 24 hours are very important. What parameters you have to assess? Yes, all vital parameters. If the systolic blood pressure is less than 80, that means and worsening tachycardia, definitely the patient has lost more than 1500 ml. Rule of 30 to follow. Systolic blood pressure fall more than 30 millimeters. Heart rate increase by 30. Urine output less than 30 ml per hour. Hematocrit less than 30. So that means this patient has already lost 30% of whole blood volume. Means she is in class 3 and she will need all the blood products, at least 444. Shock index, that is the pulse rate divided by systolic blood pressure. If it is more than 1, it indicates patient is in shock. Non-pregnant patient, shock index is 0.5 to 0.7. For pregnancy, 0.7 to 0.9. Once it goes beyond 0.9, that means your patient is in shock. 1.2 shock index is again 30% of blood loss. And this type of chart should be there in the labor room, assessment of stages of shock. In 15% blood loss, class 1, you will find not much difference in the vital parameters because still even there is no tachycardia. Systolic blood pressure will be still normal and you have to give only crystalloids. But in class 2, you will find even the diastolic blood pressure will drop. And there will be when the patient is shifted from the ward to from the labor ward, you will find sometimes she collapses. So here again, you will give her crystalloids, but immediately you will ask for cross-match blood. She may require 1 or 2 depending on her hemoglobin status. In class 3 and class 4, profound tachycardia, low BP, even the capillary refill will take more than 3 seconds or absent. Respiratory rate will be more, patient will be confused. In class 4, your patient will have air hunger. All these conditions, you have to ask for massive transfusion and immediately you have to get 1:1:1, 666. So risk assessment, again, prenatally, yes, whether there is previa, acrita, incrita, percrita, how much of the patient's BMI, clinically significant, whether she has any bleeding disorder, like whether she is APLA or any other thing, and other significant medical and surgical leaves. On admission, there could be a medium risk and a high risk on admission. Prior cesarean, uterine surgery, multiple laparotomies, multiple gestation, more than 4 prior births, prior obstetric hemorrhage, large myoma, baby's weight more than 4 kg, obesity and hematocrit less than 30 is the medium risk. High risk, placenta previa, low lying, suspected adherent placenta, platelet count less than 70,000. If there is active bleeding, there is known coagulopathy, and 2 or more medium risk factors. So these we have assessed on admission. Intrapartum, again, what is medium risk? Chorioamnionitis, prolonged oxytocin for more than 24 hours, prolonged second stage, and if the patient is on magnesium sulfate. High risk, new active bleeding, 2 or more of medium risk factors, intrapartum, either admission or intrapartum. So this is the way we have to assess. And measurement of cumulative blood loss. Now, visual estimation of blood loss, sometimes just a glance and a guess is a common practice, but there can be an error of that, could be underestimation by 33 to 50%, and there we will miss the bus. So direct measurement of blood can be accomplished by the contemporary approaches, complementary approaches. Easiest is to collect the blood in calibrated under jugs can be kept in the bucket, under buttock drapes for vaginal birth, or in canisters for cesarean birth. Second approach is to weigh the blood-soaked items and clots and the weight of the dry pads in subtract and is subtracted from the total weight to obtain an estimate. And it is not difficult. We have started doing it because recently we did a study comparison between carbotocin and oxytocin and during cesarean, and we have done it. So we should have even these type of charts, and these type of charts in the labor room will teach everybody. You have to teach your nurses and everybody that if you have these measurements and these charts put up, you will know how much is the blood loss, and quantitatively also you can assess. Active management of third stage of labor is the birth rate of every laboring woman, it prevents atonic PVH in 70%, and it is most important component in terms. Okay, and all of us are aware. I will not repeat that. Okay. Now, what are the WHO recommendations? All of us, we know now that in active management of third stage of labor, delayed cord clamping is recommended. You don't have to go on doing the massage. You can do it or check the uterus for atonicity every 15 minutes. Only if it is there, then only you can. Okay. Now response, which should be every hemorrhage. Every management plan, okay, there should be emergency management plan and critical steps to determine the etiology. Stage-based plans have been found to facilitate an organized, stepwise response to blood loss and maternal warning signs. So you also have the maternal warning sign. They ensure that resources are not wasted while each patient receives optimal therapy. Each institution needs to adjust the plan to meet its individual capabilities. Okay. So depending on the blood loss, you will have to manage. Stage 0, you are ready. You assess the risk factors, low, medium, high, active management for everybody. And if she falls into high risk, then you have already kept the cross-match blood ready. Even though patient is not bleeding, but she is high risk. In stage 1, where the estimated blood loss is more than 500 ml for vaginal and more than 1000 ml, vitals will be normal, but you have to have a big bore cannulas like 16 or 18. You have to put a catheter, do the fundal massage, increase oxytocin, consider additional electrotonics, and type and keep 2 units of PRBCs ready. In stage 2, you have to start mobilizing the blood bank support, keeping check of volume and blood products. Continued bleeding. Okay, patient is still bleeding. Then you have to draw the blood for CBC, for coagulation profile, for fibrinogen. And if it is vaginal birth, trauma, repair that. Place balloon. Apply anti-shock garment. If it is a cesarean, okay, you have to inspect for trauma. Look at the broad ligament. Go for compression suture. Okay. There could be a bleeding from placental bed. Depending on that, if the compression suture has not controlled, it is only atonic, then we may have to go for stepwise devascularization. Last resort could be hysterectomy. But you have to arrange for the blood and the replacement, not wait for lab values. Your shock index will tell you. Immediately give 4 BRBCs, throw the FFP. Till then, you are giving the platelets, and additional RBCs and coagulation products may be required. Now, in stage 3, you do not wait for anything. You have to activate the massive transfusion protocol. That means with whatever we have done for the stage 2, you are doing everything. You may ask for more support, a senior person to come, because you may have to do internal iliac artery ligation. You will also need a intensivist. You have to transfer the patient to ICU also. And aggressively, you should transfuse. Aggressively, 1:1:1. Now, support program for patients' families. Women and their families need timely information, because it is not only medico-legal, but they should know what is happening, reassurance, and opportunities to discuss the incident with the maternity care provider. Establish a culture of hurdles and debriefs need to be routine. Multidisciplinary review of serious hemorrhages. The purpose of these reviews is to identify the system issue or breakdowns that influence the outcome of the event, which I also told you earlier. And review should be sanctioned by the facility, protected from discovery in legal proceedings, and include a thorough record review, event timeline, and focused root cause analysis. Monitor outcomes and process metrics. It is important for the successful introduction of quality improvement projects. So the overall goal is to reduce the number of obstetric hemorrhages that escalate into major blood loss, resulting into severe maternal morbidity and mortality. So class 1 should not become class 2, class 2 not becoming 3, and 3 not becoming 4. Technical skills, yes, I spoke about, and there are so many methods. The UK prompt training is there, and they have proven that if these trainings are performed, definitely they found the improvement. And now Government of India has a Laksha initiative. I am working. I am also one of the assessor. We have trained the health workers. Regularly, we conduct OSCE for them, and we try to assess, because the new team comes sometimes. So we have to again train them and see how much they know. So we do conduct all these sessions for them. And obstetric emergency simulation training also required. Now, in non-technical skills are equally important, because communication, teamwork, and leadership. Now, during our undergraduation and post-graduation, we have not learned this, because unless and until there is a proper communication, this will not help. So non-technical skills are equally important for the teamwork. The team leader should have a helicopter view of the situation and should give the instructions. Because if you say start oxygen, everybody will run to start the oxygen. You have to take a particular name, be clear and louder, and give the instruction. Sisters Sunita, start oxygen. Okay, and then check the PP and pulse. Ask somebody else to get ready for catheterization. Ask somebody else to call the blood bank. Take their name. When you are asking them to give prostaglandin, say injection, Corbopras 250 microgram intramuscular, clear and louder, and the person should say, yes, madam. Now I have given injection Corbopras 250 microgram intravascularly. So the patient is in the middle. What is important is maternal safety, maternal satisfaction, and also the partner and family support. So you need individual medical professionals' knowledge, expertise, and experience. Everyone should have a situational awareness, communication skills, understanding of team members. There should be cooperation. Yes, multidisciplinary team, allocation of a leader, delegation of tasks, appropriate team members, closed loop communication, flattering of hierarchy. Okay, we don't want that. Infrastructure, major hemorrhage protocol, access to equipment, local guidelines, emergency boxes, simulation training should go on a regular basis, and antenatal and intrapartum assessment again and again to see whether there are any risk factors. So prevention and management of PPH, I will not go for that because we don't promote that. This is at different levels. You may be at a PSC, you may be at a comprehensive center, or you may be in a tertiary care center. So the people, those who are working in periphery, will have to refer the patients. Okay. So if you see a smaller nursing home where only a basic emergency care is available, so you will have a nurse aide, a midwife, a clinical officer, and resources may be not there, but point of care, they should have the facility to do the hemoglobin resuscitation, at least with fluid, monitoring all that, vitals, and apply anti-shock garment. It has to be applied immediately because it is an aid which will prevent the blood loss. They can do bimanual compression. What is the main aim is to arrest the bleeding, Give the oxytocics, do the oxytocic drill, give tranexamic acid. Okay. And repair if there are any tears. Not able to repair, pack it. Manual removal of placenta, no anesthesia. Then you will have to wait or refer the patient. And we should train the people in periphery to use the balloon tamponade. In district hospitals, we do have the OT facility. At least we should have a blood storage facility. Yes, fluid resuscitation. Cell salvage is not there in our country. NSG for referral. And if the facilities are there, then the laparotomy, uterine compression sutures, and repair of simple uterine rupture could be done there. And even they can do hysterectomy. Okay. But in tertiary care center, when the patient is referred, she may require massive transfusion. As we know, the patient may come in a bad condition, or if the patient is already a high-risk patient, not to operate in a place where there are no facilities for blood bank, or you don't have a multidisciplinary team. And it is our moral responsibility to not to operate these cases in a smaller places, unless and until you have everything available. Operating theater, radiology department, intensive care unit, blood transfusion facilities for all the blood products, and a staff available to take care. So you will need a HDU, you will need an intensive care. Now the newer drugs in our armamentarium are again the carbetocin and tranexamic acid. Now carbetocin, all of us are using. It can be used IV or IM. It produces sustained uterine contraction within 2 minutes and lasts for 6 minutes, followed by rhythmic contractions for 60 minutes. So when carbetocin is administered by IM, the contraction, rhythmic contraction will remain for 120 minutes, and heat stable carbetocin was found to be stable. And now we do have a heat stable carbetocin. WHO has recommended carbetocin for active management of third stage of labor in 2018 guideline, and says that if it is cost effective, and all of us have seen that it is cost effective because you don't require additional oxytocin. And we are proud to say champion trial was conducted in India by the Kelly Institute in 10 countries and 5 institutes in India. So WHO recommends that. So this is another alternative. Non-pneumatic anti-shock garment again is a life-saving, and we must have, every obstetric unit must have. Okay. I wish that Government of India listens to us and brings it in their guideline. And I'm happy to say Tamil Nadu already has it, and I was able to get it after talking to Government of Karnataka. And recently I shared the reports from the periphery hospitals that how the anti-shock garment can really help to save the mother by reducing the blood loss. Now, it can, after you apply it to the lower body and abdomen, thereby increasing the venous return, stabilizing the vital signs, and resolving the hypovolemic shock. Direct pressure on fundus of uterus thereby reduces bleeding, acts like an auto transfusion, and WHO has recommended it in low resource setting because it is cost effective. I have used it even in tertiary care setting. I had a patient of 24 weeks placenta previa with 60 systolic in casualty. I said, just apply the anti-shock garment and shift her to OT. Okay. So it is also helpful when you are waiting, you can wait. If you don't have a OT or your OT is not available, also you can use it. Now there are 6 segments. Place it under the woman. There are dotted line. Close segment 1 around the ankle. Close segment 2 around the calf. Close segment 3 around each thigh, and it leaves the knees free. Okay. And segment 4 around pelvis. Pressure ball over the umbilicus. And that is 5. And then you close 6. So 4, 5, 6 may be applied by 1 person, but 1, 2, 3 can be applied by 2 persons. Now, this was just to say that capillary refill more than 3 seconds or absent designate what class of hemorrhage or what percentage of blood loss will be class 3 or class 4. So such simple clinical examination can also tell us that in what stage is our patient. So thank you very much. And I must tell you that myself and Dr. Shobha Gudi are the editors of this book, which is a very simple and handy book. JP Publications, available on Amazon too. And it is a very ready reckoner type for obstetric hemorrhage. An ounce of prevention is worth a pound of cure was said by Benjamin Franklin. And I also remember one more saying by Benjamin Franklin. You tell me, I forget. You tell me, I forget. You teach me, I learn. But you involve me, I remember. So that is why the drills and skill training is so important that nobody will forget that. Thank you for patiently.
Thank you so much, ma'am, for that wonderful talk. I think that 2 most important things that you talked of was, of course, no patient is, we can predict PPH, so we have to be prepared for all our patients. And of course, the other thing that you talked of are the different medications. And in addition to that, of course, in Karnataka, I was lucky enough also to use the non-pneumatic anti-shock garment, and we know how useful it is to prevent shock in a patient, especially when we are transferring a patient from the periphery to any of the central hospitals. Carbitocin has again come in a long way, and ma'am, you have elaborated on that as well. Thank you so much for that as well. And we need to also understand that the one.
Yeah, one thing is, see, we can't have 0 PPH, but let us have 0 deaths due to PPH. Okay, yes. We should aim for that. We Absolutely. Cannot have 0, but let us have a 0 deaths due to PPH. So I think we have really served the obstetrics, I think.
Absolutely, ma'am. So I think, and also that you talked of the low threshold, in case if the medical management is not working, we shift to the OT a little earlier, maybe with all precautions with blood and blood products, and also, of course, the massive transfusion protocol, which is a must in today's day, and it should be followed for better prognosis of the patient. So thank you once again, ma'am, for that wonderful talk, for the elaborations, and thank you for enlightening us once more about PPH. Thank you, Komal ma'am, once again for giving us this opportunity.
Thank you.
So two things, recently in FIGO guidelines I have read is, one is DCR and DCS. Okay. So disaster control resuscitation. Whenever we see a patient with a severe PPH, it should be disaster. There is already a disaster control resuscitation and disaster control surgery. So these are the 2 things which terminologies are given in FIGO guidelines.
Yeah, damage
that is
control surgery.
Recent 2022 guideline which has come. Yeah.
I think apt, really great lecture. I think I've heard so many talks of PPH, but the way you have said today with all the point format, how to act, how to go about at every step, it was a real guiding talk, and it is really going to benefit everybody. Yeah, even I was listening every word of it. So beautifully you have elaborated the response team, how to keep checks constant. The preparedness is, I think, the key, which you have highlighted very, very well. So thank you, madam. Thank you. It was a wonderful presentation. And we will definitely share the recordings also. I think there are some lot of comments also about suction cannula and PPH and other things. So this is a question to you,
yeah,
madam.
I will just talk about that.
Fine.
Recently, I had an opportunity to have a live demonstration of SR cannula with Dr. Samartharam. And I must tell you that it really works. The way uterus contracts, you know, it is very, very helpful. And now I have started using it. And that day I used it, you know, the amount of blood loss after cesarean was 50 ml.
Wow.
It was 50 ml. Okay. And anyway, day before yesterday, I used it for a vaginal delivery because the patient had PPH. Okay. But in this cesarean, which I did, RH negative patient, so I used it prophylactically, only 50 ml. And the way uterus retracts and contracts, you won't believe, you know, it really is doing, it is very helpful. And I must tell you that in Karnataka, many people are using, and Andhra, every government hospital has. Every government hospital, they have it. And seeing is believing. And I must thank him that he came to our institution and he demonstrated 2 cases of cesarean section. And we have it now in our OT as well as in our labor room. So, yes, definitely it has replaced balloon tamponade, I can say.
Yes.
Yeah. And there is a separate cannula for vaginal delivery. It is angulated. So it won't come in your way of episiotomy suturing. Okay, it goes up like that. And you can suture the episiotomy. Okay. So you have to really watch that video. I mean, all of you are known to me. I can share that video also with you people and all of you can watch it. Okay. So thank you.
Thank you. Thank you, madam.
All the
Okay,
best.
after the initial,
your future endures. Okay. In this PPH, you know, I get so much carried away. So wishing you all the best.
Thank you, madam.
Okay?
thank you so much, ma'am, for
Thank you so much,
such an
ma'am.
enlightening session
Thank
for
you.
all the participants.
Thank you, Madam Dr. Sheila Mane, for joining. You are the PPH lady of India, not only of India, of the world, and we are really honored to have you today. Thank you, Madam, for coming.
Thank you. Thank you.
Welcome, Dr. Niranjan, sir.
Thank you, Madam. Thank you, Anu.
Okay, after the initial resuscitation, let us move on to the next session on systematic devascularization. I welcome the chairpersons. Please show the CV slide. Dr. Anju Thuriyar, madam. She is the director of Matritva Clinic and she is coordinator for Bihar State of SSNPP, president of BOGS, and past vice president of AOGS BG, and she is zonal coordinator for Family Welfare Committee. She has participated as faculty in various national and international conferences, recipient of many awards, and her field of interest is mainly challenges in obstetrics and infertility. We welcome you, madam.
Thank you. Thanks for your kind words.
Thank you, ma'am. I welcome Dr. Amita Saxena, madam. She is She has received advanced training in aesthetic dermatology from Skin Institute of Singapore. She is director of Saxena Cosmetic Clinic and has received advanced training in Botox and fillers from Allergen. She is president 2020-23 OBGYN Society of Jabalpur, and she has been the vice president of Indian Menopause Society and Jabalpur Obs-Gynae Society, state coordinator of AAO Gandhian Sanskaram PB. MP, and she has published many papers in international and national journals. And thank you, madam. We welcome you to the session today.
Thank you so much.
I request the chairpersons to please introduce
Shall I introduce her? Shall I introduce her? Dr.
Okay,
Shashi. Okay. Welcome, Dr. Shashi Kabra, a good friend of mine. You are a senior specialist of Obs-Gynae and NBE teacher in DDU Hospital and Health Services. She's been the president Delhi Gynae Forum of Southwest. She was the chairperson PCPNDT committee West District, Delhi. IMA Appreciation Award was given to her in 2018. She was a recipient of Wanda Foxy Award 2019, APJ Abdul Kalam Appreciation Award in 2020, and IMA WDW Karamveer Award in 2021. She's also received the Champions Awards in Ops and Critical Care in 2021. And again, APJ Abdul Kalam Excellence Award, DGF, in 2022. She's got so many awards to her credit. All the laurels are there. She was the Asia GCC Award Quality Leader Health for Healthcare in 2021. She also received the Rashtriya Gaurav Award in 2021 IFS. She is the National Mentor of Laksh in association with AIMS Delhi, GOI, and WHO. And she's been a member Practical Ops Committee FOXY and Medical Education Committee FOXY. And she's organized 65 workshops on PPH all over India. Her topic is systemic devascularization, which is a burning topic nowadays. Every third obstetrician is talking about it. And that because this age is of saving the uterus. So devascularization is definitely preferred compared to hysterectomy or hysterotomy and all. And I think she will tell us in detail about it and she'll do justice to this topic. Welcome, Dr. Shashi.
Yeah, thank you, Dr. Anju Churier. Thank you so much for such a kind introduction. And my special thanks to Dr. Komal and Dr. Niranjan sir, and my special regards for Padma Shri Usha Sharma ma'am and Dr. Krishnendu, and special regards for the PPH lady Sheila Mane ma'am, and for the coordinators, Dr. Shreya and Dr. Anusha. So let's begin. I am sharing my screen.
In the meantime, I would like to thank Dr. Komal and Dr. Niranjan Chavan for inviting me on this platform. And my sincere regards to Sheila ma'am, Usha ma'am. Okay, you've started screen sharing. Okay, let's start your screen. I'll continue it later.
So is my screen visible?
Yeah, it's visible.
Yes. Yeah. So my topic is step-by-step devascularization. And in the beginning of my talk, that I want to say that with, as Madam has said, with drills and skills, if we learn it regularly, then we can convert a nightmare of PPS to an expertise. And at this moment, I would also like to say that now it is becoming more and more important to learn internal iliac artery ligation as we are getting more and more cases of placenta percreta spectrum disorder. So this is a very beautiful picture. All of you have seen in your textbooks. So here you can see that this is the area where we ligate the uterine artery. We ligate the uterine artery at two levels, upper and lower. And we ligate the anastomosis of the uterine or ovarian artery. In books, it used to be written ovarian artery ligation. The word ovarian artery ligation is a misnomer because the ovarian artery is here, a direct branch of abdominal aorta. We do not ligate it here. Rather, we ligate the anastomosis of the uterine branch of ovarian artery and ovarian branch of uterine artery. So I'm just coming to video sessions. Just let me know if my video is running. Is it running?
Yeah.
Yes. So this is a case of cesarean section where I had to do a uterine artery ligation. So bladder is pushed down. I'm palpating the uterine artery. I usually take number 1 Bacryl or number 1 catgut for the ligation of the uterine artery. Take a by 2 centimeter of the myometrium and from anterior to posterior, take out the needle. It is taking the part of myometrium also. This is very important. Now you fan out this part, find an avascular area in the broad ligament and get the needle from posterior to anterior side. Tie the knot securely, 2 turns in the first knot, then single turn in the successive knots, each in reverse direction. Now, distal ligation is done 2 to 3 centimeter below the proximal ligation. Same technique, take a part of the myometrium, approximately 2 centimeter. Go from anterior to posterior. Then again find out an avascular window in the broad ligament. Take the needle out from the posterior to the anterior side and tie 2 turns in the first knot, which is a part of the surgical knot. And similarly, it is done on the other side. It's better that we should always perform bilateral uterine artery ligation. Now coming to ovarian uterine artery ligation, not ovarian ligation. This video was shared by my friend Dr. Soma. Part of myometrium taken. Going from anterior to posterior side. The place for anastomosis is here. This site is medial, at the medial end of the ovarian ligament. Coming from posterior to anterior side. And the anastomosis is in between these 2 bites. Two turns in the first knot. And this is how this anastomosis is ligated. So now coming to the most important part of internal iliac artery ligation. Dr. Sheila Mane was talking about FIGO guideline 2022. And this was an additional information in the FIGO guideline that every obstetrician should learn internal iliac artery ligation because it is a life-saving procedure. So let's go back to our anatomy classes of first year. This is the abdominal aorta, the biggest vessel of our body. At the level of L4 or L5, it divides into 2 common iliac arteries. And each common iliac artery again divides into external iliac artery and internal iliac artery. If you look at this picture, then you see it makes this abdominal aorta makes an inverted Y here, which is centrally placed in the body. And then each successive common iliac artery makes 2 inverted Ys separately. And we are concerned about this inverted Y, which is made by the bifurcation of the common iliac artery into external iliac artery and internal iliac artery. External iliac artery is continued below the inguinal ligament as femoral artery. It has a bigger lumen, and the internal iliac artery goes posteromedially, and it has a smaller lumen compared to the external iliac artery. And if you look at this picture, then this is a part of one side of common iliac artery, which divides into external iliac artery, and this is lateral side, this is medial side, this is internal iliac artery. And now when you look at this, then you see that immediately after its origin from the common iliac artery, this internal iliac artery gives a posterior branch, which has mainly the parietal supply. But we have to ligate the anterior division. So in a pool of blood, we cannot see the posterior branch. So how to identify this place of ligation? This is around 3 to 4 centimeter from the bifurcation of the common iliac artery. So what I do, I just make a place 3 to 4 centimeter from this and I ligate the artery. Here you can also see that the internal iliac vein is just behind the iliac this artery, and these both are embedded in a sheath. So this section is very important to pass this mixture forceps in between the vein and the iliac artery. So, how internal iliac artery works? Bilateral ligation results in 85% reduction in pulse pressure and 50% reduction of blood flow. And this converts an arterial flow into a venous flow, which is a very slow flow. And this facilitates coagulation. Bleeding is reduced, and it is really a life-saving operation. It is initially technically difficult, but then one can quickly learn it fast. It is that learning curve is not as prolonged as in laparoscopic surgeries. One can perform internal iliac artery ligation after doing 2 or 3 under supervision. So these are the two important things which I use during internal iliac artery ligation. This is mixture forceps or a right angle forceps. It is bent at right angle, but this tip is blunt. And then I usually use number 1 silk for internal iliac artery ligation. And if silk is not available, then I use number 1 bicrate and just double the thread like this. I will show you why it is used like this. So this is a model of uterus which I made myself for my students. When I used to do internal iliac artery ligation in my own hospital, and I used to ask the students to assist me, then they used to make mistakes because they do not know the anatomy very well and they used to get confused. So that had given me an idea of making a 3D model for them so that they can understand the different structures. So just please tell me whether the sound will come in this video. This is common iliac artery. Is sound coming?
Yes.
Yes,
We can
ma'am.
hear you.
Okay, okay. So just see, this is a 3D model which I made. Here you can see that this internal iliac artery is embedded in a sheath with the internal iliac vein, and this is external iliac artery and external iliac vein. So you just see this. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize. This is how the internal iliac artery needs to recognize the site of ligation. This is the case. Right angle forceps, also called mixture forceps. It is bent at 90 degrees and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral to medial. Always remember that right angle forceps pass from lateral to medial on both the sides. I will get hold of the loop and just gently I will come out like this. This movement is very, very gentle. Now next step is I will cut this and make 2 threads. This is the double thread. And this is another thread. So start playing them. This is plain and this is another thread. So look at the technique of applying ligature. I have taken hold of one ligature. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn. And I have tied it here. Then very gently I applied the second throw. And again very gently I applied the third throw. This is to be done without pulling the artery. I myself cut this. Just without giving any pull on the suture, I cut this. I'm just putting this. So now I will show you a live video just based on this. This is common. So the main important point is technique of passing the right angle forceps of mixture. Forceps, this is the right technique. Right angle clamp is passed from lateral to medial side below the internal iliac artery like this, never like this. If it is passed like this, then it will come through the medial side and hit the external iliac vein and cause injury in the external iliac vein. So this is the correct method of passing the mixture forceps. So now there was a case, 26-year-old primary gravida with full-term pregnancy. She was booked initially in one facility and then her ANC was done at one Anganwadi center. She had labor pain on 23rd November and rushed to 3rd hospital at night. There she went into obstructed labor and taken to another 4th private hospital. Just imagine how many hospitals this patient has visited. And then she had undergone emergency cesarean section for second stage arrest under spinal anesthesia at 8 a.m. in the morning. She had an episode of PPH at 10:15 a.m. after, and that was managed medically. Then she had another episode of PPH at 12:30 p.m. and she developed shock. So the doctors took her to operation theater, and what did they find? Under sudden anesthesia, left atrial cervical tear, which they repaired, and they found a posterior vault repair, which was so that was very significant, and they repaired it under spinal saddle block anesthesia. This time, patient received 4 units of PRBCs, 4 FFP, and 2 platelets. Then again at 7:15 p.m., that means almost after 11 hours, the patient again went into shock. And this time she was resuscitated and referred to me with 5th unit of PRBCs on flow. That means when this patient was referred to me, she already received around 10 to 11 units of blood and blood products. So when we received the patient, her pulse was 146 per minute, but BP was stable, 104/60. But here lies the importance of shock index. Her shock index was still 1.4. That means that the patient was in shock. So I took no time. I did not waste time for doing any conservative method. I just thought of opening the abdomen. And so the abdominal finding as such were uterus was contracted, abdomen was soft, and there was no significant mass palpable, but vaginally there was moderate to severe bleeding. So I opened the abdomen by a longitudinal incision because I was anticipating problem. And what could I see? There was a huge broad ligament hematoma extending from the fundus to the posteriorly reaching up to the vaginal vault. So, and the uterine artery was retracted. It was not seen. So I performed a very quick obstetric hysterectomy in this case and performed internal iliac artery ligation because there was oozing from different part of apparatus in the pelvis. So I'm showing you a live video of this. In this case, as you know, that the uterus was already removed. So I followed from the pedicle of the round ligament. What we have to do is that you have to make an incision in the retroperitoneum or anterior broad ligament peritoneum, following the round ligament, and we move laterally towards the parallel and lateral to the infundibular pelvic ligament, and we try to open the peritoneum to the lateral pelvic wall at least around 4 to 6 centimeter, and that opens the loose areolar tissue. So you just see this video. You see, this is the round ligament. This is the round ligament. I'm cutting the peritoneum here, going parallel to the infundibular pelvic ligament, and every time I'm cutting the peritoneum, I'm seeing below, and I'm cutting only the thin peritoneum so that the underlying structures are not injured. Now I have kept all the instruments, and since it is a loose areolar tissue, I'm separating it only with the fingers. If you look at this picture, you see, this is the ureter in the medial fold. So never get afraid of ureter when you are performing internal iliac artery ligation. It always remains in the medial fold. And this is the inverted Y I was talking about. This is the common iliac artery. This is external iliac artery, and this is internal iliac artery. Now you see how we dissect this. This is the ureter in the medial fold, and we are working laterally. This is medial side, this is lateral side. I'm making it more prominent. Unless you recognize your structure, you do not operate. So first I will make sure common iliac, internal iliac, external iliac, ureter. Now I'm pressing the common iliac artery and palpating the femoral artery. If I'm pressing the external iliac artery and palpating the femoral artery. When you press external iliac, the femoral goes. And again, I press the internal iliac artery and there will be no change in femoral. Now I have already, as you see, we have to recognize the site for internal iliac artery ligation. So it will be around 3 to 4 centimeter, and that I've already shown you in my model. With my thumb, I measure this distance. So now you see at the proposed site of ligation how I do the dissection. I'm separating the sheath which encloses both the internal iliac artery and vein, and separating nicely. My movement is parallel to the vessel. You see, can you see here? Appreciate the internal iliac vein is just lying below. This is the internal iliac vein. So you can see here that at the proposed site of ligation, I made a space. Now this is being passed from lateral to medial. This is the mixture forceps, and the thread is already ready. The loop is already ready. And I'm pulling it gently. The arterial wall is very thick, so you have to graze your instrument with the arterial wall. And venous wall is thin. The bigger the vein, the thinner the venous wall. Now I've cut it, and now with the single thread, I made 2 threads. The purpose of making the double thread is this, that you pass your right angle forceps only once, and this causes less injury. Now, I will try to play the threads, which one is which one. So this is what I'm doing it very gently. Assistant's job is only to show me the area. This was my 100th of internal iliac artery ligation. And this is an otherwise unedited video. So I've recognized the thread and given 2 turns in the first knot, and going and bending my back and head to place the knot on the superior surface of the artery. As I've told you, no pulling. Second knot, again I'm taking finger inside the abdominal cavity. And the third. And very gently, I cut the thread myself because my assistants cannot understand how much to pull. So here I cut it myself. Then you see the first ligature here. Now second thread is taken in my hand. Again, similar method, 2 turns in the first knot, as I've shown in my model. And make the knot square. Always make the knot square. Go below, bend your back, bend your head, salute the artery that you are the biggest vessel of the body. I'm bowing my head in front of you, and apply the ligature. So 2 ligatures have been applied. We applied 2 ligatures on internal iliac artery as it is one of the third biggest vessel of the body, and we never cut it. So you see here, very well you can appreciate 2 ligatures, 1 and 2, and there is a distance of 0.5 to 1 centimeter between the 2. This is the psoas muscle. This is, if I freeze, if you can see that the ligature is on the internal iliac artery and the external iliac artery is lateral. So these are my own tips for internal iliac artery ligation, which I made after my 20 years of experience in Deen Dayal Upadhyaya Hospital. This hospital has a delivery rate of 10 to 12,000 per annum. So open the retroperitoneum. This is the anterior approach which I've shown you. So for the and there is one more called posterior approach. So for the posterior approach, you open the retroperitoneum. For the posterior approach, you make a nick in the peritoneum 2 centimeters below and 2 centimeters lateral to the sacral promontory on both the sides. And for anterior approach, you open the retroperitoneum from round ligament to infundibulopelvic ligament, which I've shown you in my video. Then once you open the retroperitoneum, leave all the instruments, keep away all the instruments, and only do finger dissection in the loose areolar tissue. Then next step is locate the bifurcation. Unless you recognize the inverted Y, don't proceed. You try to find the inverted Y. Then you recognize the internal iliac artery as the medial structure, which does not cause any change in femoral pulse. You will doubly confirm it first by pressing the external iliac artery, then the femoral pulse goes, and second by pressing the internal iliac artery, femoral pulse will remain unchanged. Then movement of your mixture forceps or right angle forceps always from lateral to medial. Remember the word lateral to medial on both the sides, lateral to medial. Then careful knot tying in the cavity. I've shown you 2 turns in the first knot, surgical knot, and bend. Never pull the artery. Then 2 ligages to be applied 0.5 to 1 centimeter apart. And last but a very important line is that always do bilateral internal iliac artery ligation, because the literature says that the chances of free laparotomy and morbidity increases when we perform unilateral internal iliac artery ligation. I have seen in many cases real laparotomy done and patient could not survive. So thank you so much for the opportunity. And I seek your valuable vote for my ICOG Governing Council member election this year.
Thank you,
Thank
Dr.
you, madam.
Shashi. It's Dr. Saxena's turn to speak. But
Thank you, madam.
Yeah, just a minute. Her presentation was so good that I could not stop myself. Excellent deliberation. The practical approach and the video was so beautiful. No, it's just commendable. Apart from this, thank you, Dr. Saxena, for giving me the time. And thanks to all our seniors who are here. And thanks to Dr. Komal Chauhan and Dr. Niranjan Chauhan for having me on this dais and sharing it with the all stalwarts. Thank you, Dr. Amita. You can proceed.
Okay. Thank you so much. Thank you, Dr. Shashi, madam, for the wonderful talk, and especially the demonstration of the video of uterine artery and internal iliac artery ligation, which I think every obstetrician must know. I must congratulate and thank Dr. Komal and Dr. Niranjan for making me the part of this important webinar. And thank you all the seniors, especially Dr. Sheila Mane, madam, for the very elaborative and wonderful presentation, which you all made me learn so many things. Thank you all. Thank you so much.
Wonderful. Actually, I loved the videos.
Yes,
Dr. Shashi,
it was really, really good.
Thank you.
I think use
Actually, regular
gave
revision
very
is
practical tips.
practical
Very
tips, very
practical tips.
Very.
And you made it sound very simple and easy also.
Yes.
So I think
Thank
most
you.
of the I think we have covered PPH really well till now.
You must share the video, Dr. Komal. Must share the video for other
Yes,
those
we will be, because this video of this.
Yeah, I can
episode
share
will-
it through Telegram, so it can reach anyone.
Yes. So Dr. Amita and Dr. Anju, thank you so much for being here. It was a lovely session.
I must thank you for making it the part, because
Yes.
this is the way we keep learning too.
Thank you. Thank you.
Exactly. We learned quite a lot today.
Yes.
From
Thank
Sheila
you.
ma'am also, and from Dr. Shashi Lata Kabra
They
also.
both are so expert in
Yes,
their field.
really.
So we really get to hear from
Wonderful speakers.
directly from their mouth. So it is really a
Made
great
it so
learning.
easy to learn.
Yes.
Actually, what we see, we always remember. What we study or read, we don't remember.
We
And
forget,
this is
yes.
what Shashi has shown us right now. Thank you, Dr. Shashi.
Thank you.
And all the best, Dr. Komal and Dr. Shashi, for your elections.
Yes,
Thank
Shashi,
you,
wish
thank
you
you,
all
thank
the
you.
best. Thank you so much for your wishes,
The
Anju.
successes in you both.
Yeah, best wishes to you too. Thank you so much for your wishes.
Thank you.
Thank you.
Thank you, Sashi Madam and other chairpersons. Let us move forward to the panel discussion. I request Dr. Shreya Prabhu Madam.
Yeah.
Please take over.
Before we can start the panel, I want to say something about Dr. Shashi. Madam, I have seen so many internal iliac videos and I have also operated, but I have never seen such a beautiful explanation of the 3D model which you have done for your postgraduate students, and also the technique which you have showed very nicely. Rather than going 2 times separately with the mixture from the lateral to the medial, you can go only once and then cut
Yes.
the scissor so that you get 2, double equal linen or double equal, say, black silk, So that was a very nice way of explaining. And you made it so simple that even a registrar can also do. And
So
that
this
is,
is what we are wanting.
so thank you.
Thank you so much, sir. Yeah.
I hand over now to Dr. Shreya Prabhu, madam.
Thank you,
Please
Anusha. Thank you, Komal ma'am and Niranjan sir for giving me this opportunity. We had a fantastic time listening to the talks. Both the talks were very good and very practical. Thank you, Sheila Mane ma'am and Sashi ma'am. Without further ado, I would like to introduce the moderators for our panel, which is on placental problems and obstetric hemorrhage. So I would like to call upon Dr. Komal ma'am, Dr. Komal Chauhan. She's a
We have been introduced, Shreya. You can go ahead.
Yes,
So introduce
yes.
the panelist, our
Yes,
esteemed
so
panelist.
so our moderators, Komal ma'am and Niranjan sir, and going ahead to our panelists, I welcome my panelist, Dr. Achala Batra. Madam is a consultant obstetrician and gynecologist at Mata Gujri Hospital in Delhi and an ex-professor at VMMC and Safdarjung Hospital. Madam has been a president of AOGD 2021-22. Welcome, ma'am. Moving ahead, Dr. Indira Palo. Madam is an associate professor at MKCG Medical College and secretary of Behrampur Obstetric Gynec Society, life member of FOXY and various other organizations. Welcome, ma'am. Next, Dr. Latha Chaturvedula. Madam is a professor at obstetrician and gynecology at Faculty of Medical Education, JIPMER, Pondicherry, and president of Obstetric and Gynec Society of Pondicherry. Ma'am, welcome you here. Dr. Kiran Sonwalkar, sir is a secretary of Satara Obstetric and Gynecology Society and a committee member of FOXY Medical Legal Ethical Committee. Welcome, sir. Dr. Rajeshri Katke, ma'am. Madam is a professor and head of unit of Department of OBGY at Grant Medical College and ex-superintendent of Kama Hospital. Madam is very well known for her academics and she's a member of various committees. And she's also a professor and unit head of Varkidas member. She's a department DQAC committee member of maternal mortality. Welcome, ma'am. Dr. S. Lavanya. Madam is, she is working at KAPV Government Medical College, Trichy, and of Institute of Obstetrics and Gynecology at Madras Medical College. She is trained in laparoscopy at Paul's Hospital, Cochin, and infertility at Asha Hospital, Coimbatore. Welcome, ma'am. Dr. Nivedita Datta, Madam is president of Bokaro Obstetric and Gynec Society and consultant at the KM Memorial Hospital and Research Center Private Limited, Bokaro. Welcome, ma'am. And Dr. Alpana Chetri, Madam is an associate professor at CSS College of Obstetrics and Gynecology and Child Health, Kolkata, and joint clinical secretary of Bengal Obstetric Gynec Society for the year 2022 and 23. I welcome you all, ma'am. With request Dr. Komal ma'am and Niranjan sir to continue.
Thank you. Thank you so much, Dr. Shreya. And I think with the wonderful talk by Dr. Sheila Mane and Dr. Shashi, the lovely videos, half of our job has been done. We have really gone into depth of management of PPH. And now we are left with something which is really going to the cause and the effect. That is how are the placenta and how it is affecting the obstetric hemorrhage, causing a massive hemorrhage. That is now what we are going to discuss. So welcome all the esteemed panelists. I know everybody is from a medical college or a background and must have seen enormous of these cases of placental disorders and obstetric hemorrhage. So I welcome you all. And we know that bleeding in pregnancy at any time trimester can be so catastrophic. And managing these bleedings is so challenging because we really need to stabilize this patient with whatever limited resources we have. It may be in a small nursing home, a private clinic, or a tertiary institute, but this can be really unexpected. So early recognition is the key, and that is what Dr. Sheila Mane has so emphasized. Preparedness is so vital, and the management and having skills of doing the end stage management, like how the patient was referred when Dr. Shashi spoke, and ultimately it landed up to a tertiary institute where she could do justice to the patient and do the life-saving procedure. So that is what it depends upon the outcome, that is both maternal and the fetal outcome. So we will begin with our case discussion, and we have here a Gravida 2 with 1 abortion, 32 weeks of pregnancy, coming with bleeding PV since 1 hour. Patient is ANC registered, diagnosed case of gestational hypertension on labetalol, and on examination, pulse is 100, blood pressure 124/80. The systems looks okay, but per abdomen 32 weeks, a tonically contracted uterus, and fetal heart sounds 156 on Doppler, little reassuring, but bleeding per speculum. So my question to Dr. Achala Batra, I think the diagnosis is very evident, but you can just throw a light. What comes into your mind and what are you going to do the next?
See, well, like you say, diagnosis is very obvious. Painful bleeding in a patient who has hypertension. The first thought which comes to our mind is placental abruption. Now, what we have to see is that what is her general condition, what we have to do. So she is only 32 weeks of pregnancy. And so we have to think about the mother as well as the baby. Her general condition, we can see the pulse has increased. So it means she has bled some amount inside. Maybe the pulse is also more because of her pain that can also increase the pulse. The blood pressure is okay. The blood loss of 150 cc outside.
The ultrasound was done, showed a blood clot of around 150 cc.
So a 150 cc blood clot is pretty huge for a retroplacental clot. And this patient can, because of this, can go into shock and DIC both, because placental abruption is very notorious for causing DIC.
Yeah, I think we can go into management a little later, but I really want to now ask Dr. Lata, can we actually predict, placental abruption? Does this patient have any high risk factor for it?
Yeah, she is having one thing is abortion, and secondly, the most important is hypertension. So in these patients, and even sometimes we have seen abruption occurring at 120/90 and sometimes not even that. Of course, there are others like over-distended uterus and trauma to the abdomen and things like that. Polyhydramnios can cause, especially in multiple pregnancy, it can be anytime during antepartum or intrapartum period. So these are very common, and sometimes big baby or sudden rupture of membranes. PROM, especially with over-distended uterus, yes, these can have. So she has definitely hypertension.
Yeah, and classically, even all the books mention the folic acid deficiency. It is related to abruption.
Abruption, yes.
I think we need to even remember that supplement.
But I think most of us, though we say prophylactic is only with iron and that 400 microgram, I'm sure all of us are giving 5 milligram of folic acid to many of these patients. So luckily, I think that is taken care of. And I mean, most of us I've seen, everyone, though we say it's not necessary, but I'm sure I can watch all of us give folic acid.
All of us are giving it, yes.
Yeah.
And the external cephalic version, which we hardly do now. But
no, don't say that. We do a lot of external cephalic version. Unfortunately, Terbutaline is not available, so that is creating a problem. But otherwise, any breach, unless proved otherwise, external cephalic version.
I totally agree.
We are showing procedure of cesarean hysterectomy in a patient.
Yes, Dr. Achala, I think you're talking about the external cephalic version.
I said I agree with her, Dr. Lalita, that we should be doing ECV.
ECV. So good that we are still doing, and the art of ECV is still there. So really happy about it. So evaluation, as I think Dr. Achala mentioned earlier, that it is very important for the maternal hemodynamic condition. We need to stabilize. We need to quantify the blood loss. She's already mentioned, and ultrasound is diagnosed. Now, coming to the investigation, I will go again to Dr. Achala Batra because we just left the discussion halfway. What investigations you will send? What are the must investigations?
This patient must have a hemogram, of course, and then a coagulation profile is a must for her. And since she has abruption, which we don't know whether it will increase or stop there, so we must have a baseline organ functions for her to know that if she deteriorates, we have a baseline LFT and KFT for her. We must arrange, if we know her blood group, all right. If we don't know, we must do a blood group and arrange and cross match. For this patient, otherwise we say that only blood, but for this patient, she is prone to have DIC. We must arrange besides blood, FFP also, because she can go into DIC because of this condition. Other bleedings, we can just arrange blood. For this abruption, we must arrange blood as well as FFP together. And we have seen her pulse is 100. And if you see the shock index, it is just a little more than 0.9. So we have to be very careful, and like new charting we have to do for her, we have to keep repeating her pulse, BP, urine output, and of course, capillary refill, like Dr. Sheila Mane has said, for the shock, because this may not manifest externally. So we will only know by that chart, how much blood she is losing inside, and then we have to, replace accordingly.
Yes, and this is just the RCOG guidelines which I'm sharing. So investigation, what you mentioned, definitely are the must. But other tests like sending a sure shot confirmed patient for an ultrasound, it is not a very strong guidelines, or even doing our RH fetal-maternal hemorrhage and everything. It is not that relevant at this time. Now coming to the fetal well-being, Dr. Kiran, how will you ensure, because we know that now the mother is having an abruption. So what measures you will take to ensure the fetal well-being? Dr. Kiran, if you are there, I think he's there.
Yes. We will first monitor fetal heart sound, FHS monitoring, and also we will do the ultrasound to see the amount of blood clot and the fetal condition. This will do for fetal monitoring.
Yes. So I think ultrasound will give us a lot of guidance, and even a CTG, if you don't have an in-house ultrasound in your labor ward, even putting on a CTG machine will tell if the fetal heart sounds are stable, if there is a beat to beat variability, are there any deceleration? So everything can be evident on a CTG. So CTG will be important, and patient should be on a continuous monitoring. That is what is very important. So coming to Dr. Rajeshri Katke, I know she must have seen a lot of cases of abruption. And so how can you differentiate? Sometimes the patient may not have a very evident abruption. It will be a concealed format. So how do you really assess for the patient when she doesn't have that evident bleeding?
See, first is on the history, we can come to the conclusion that whether how much is the amount of the bleeding is there or not. On general examination, it is very important to know whether the hemodynamically, tachycardia, blood pressure is associated with the amount of the blood loss. Sometimes if it is in a concealed variety, there will be amount of the blood loss in the uterus will be more, and the patient will not have a revealed bleeding much more in that. Here is the one thing where we can, misunderstood the loss of the internal bleeding in a concealed variety. So basically, that is the one thing. Second thing, on the per abdomen also, the height of the uterus will be more than the period of the amenorrhea, where the fetus and the concealed bleeding will be more. It will be tonically contracted, and in such cases, the fetal demesis will be more in that. So this is about the concealed. In a revealed this thing, you will get the more amount of the bleeding, and it will be, less fetal. There is a chance of, having a fetal heart rate even maybe in a good condition, and you can take the measures very correctly. But ultimately, the concealed variety will be more dangerous to the mother and the fetus. So the amount of the blood loss which looks revealed into the eyes, it is important to treat them, but it is more important to treat and suspect or anticipate the blood loss which is in the uterine cavity. And there is a skill where, we should get in that. And second is that amount of the inside bleeding will give more complications like consumption coagulopathy and the fetal demesis. I think that is how one should differentiate clinically. Now, of course, if you have an ultrasound in the labor ward, definitely now Dr. Achla has told she has 150 gram of the blood clot. That means it's a major one. So that is the one of the added thing. But basically, a good clinical examination can give rise to the best opinion and added with the ultrasound.
Yes, very rightly pointed out, and we know the complications are there, and I think
coagulation disorders, PPH,
pointed out very well. And the management, like the immediate attention, I think Dr. Achla has pointed out very well. But coming to the definitive management, and before we go to the definitive management, I just want to ask Dr. Lavanya, what is the role of corticosteroid? Because now we have this patient at 32 weeks. Should we give corticosteroids? What is your take on it?
Madam, now she's 32 weeks and we have an acute problem in front of us, that is an abruption and causing a major problem to the maternal and the fetal life. So of course, there is no wrong in giving a shot of corticosteroid, which might help, but still waiting for the corticosteroids to act is not a sensible option right now. We have to go ahead, look for the chances of vaginal delivery based on the maternal and fetal parameters. Look for the possibilities of vaginal delivery and go ahead and not exactly wait for the corticosteroids to act on the maturity, because we have bigger problems to handle right now.
Yes, so this is very important. All the guidelines said you can give a single dose of corticosteroid. The patient is between 24 to 34, but very rightly said by Dr. Lavanya, we do not wait for the action to come. We just give it and do our plan of management, because and a single dose also helps. So that is what they have said.
And it helps, if you give surfactant also in that, So basically, a single short dose will be very beneficial to the fetus.
Yes, that is very important. That I wanted to. And tocolysis, and this is the evidence. I just wanted to put it.
No, never.
No. So it's very, very important that there is no role of any tocolysis or anything when we are actually giving for these patients with APH. These are the green top guidelines. So now coming to the definitive management.
I would like to comment on the tocolysis part. Actually, it depends on, it depends even on where the patient is at the present. If she is not in the tertiary care center and the patient is relatively stable, at least to transfer the patient to a higher tertiary level, and for looking at the facilities and the NICU facilities, we could at least give a tocolytic in this certain, it's not a no-no, but still if you have to see that the patient is hemodynamically stable and the baby is premature, we can at least opt for tocolytics.
Yes, it is a great evidence, grade 4, that if you need to transfer the patient and you know that the findings are not there, that is the time where you can actually consider giving tocolysis. But first,
Dr. Komal, sorry, I would like to differ out here.
She should not have any tachycardia or hypotension, otherwise it will get again precipitate the her conditions in that.
Yes, definitely.
And in a concealed variety, you will not able to assess whether she is bleeding inside.
So that's why I commented she should be hemodynamically stable. And since the patient she is around 32 weeks, this tocolytic may also act as a neuroprotective, neuroprotection for the baby. So that is a double-edged, benefit. Or whereas this. When it's not a totally no for a tocolytic, if you think that
not recommended after 32 but weeks, it can be considered in a rare case.
It can be considered, yes, exactly.
Rare cases, because we really don't want to give a message that you need to
give this message of tocolysis at all, because after this seminar, people will start giving tocolysis. So this is something which is
no tocolysis. No, there is strictly, it is written that there is no role of tocolysis. You really don't have to give it. But only thing is what Dr. Alpana said, that is very rare, I think. And I think the transfer should be as swift, not needing a tocolysis. So, and delivery should be very imminent. Now, $1 million question, Dr. Nivedita. Vaginal delivery, when and how will you assess?
The assessment is purely on an obstetric point of view, depending upon your, because you have to deliver this woman. She is got abruptio, she's probably deteriorating. So you need to deliver. If you find the vaginal signs are good, because normally abruptio placentae, they progress very rapidly. So vaginal deliveries are pretty smooth in abruptios. However, if you find that the os is closed, the cervix is unfavorable, the Bishop scoring is poor, then it is better to go in for a C-section.
Yes. So I think vaginal delivery, what about the take of everybody, Dr. Achla?
Definitely vaginal
Rightly,
delivery.
Dr. Rajshri said you do a PV, do a Bishop score, you find it very phase cervix. Even if it is 3-4 centimeter dilated, you can do a ARM and lever for vaginal delivery.
Absolutely, absolutely. If the Bishop scoring is good, you can augment the labor and give her a vaginal delivery. But if the Bishop scoring
considering
is very poor,
baby is CTG, continuous CTG monitoring, baby and maternal conditions are stable, and at any time anything deteriorates, you take care of first.
Yes,
and normally both of them deliver if the cervix is favorable.
Yes.
One has to
highlight
be
the advantages of amniotomy in this case.
One
Yes,
is that it causes
definitely.
decompression. Yes, amniotomy causes decompression of the uterus. So, sorry, it causes again compression of the uterus and decreases the amount of bleeding. So, the one is that the sudden you will find this the patient profile might improve after amniotomy. So, one amniotomy is always recommended. One always do amniotomy if possible.
And also release of the prostaglandins that may initiate also for activation of the liver, and we want that in a.
We really want. So I think when we get a
we
patient,
were taught that even if it is one finger and you can get in your coccus artery fossa through that, do amniotomy through that. Do an early amniotomy in this.
so early amniotomy is recommended, and the advantages I think everybody has enumerated, and definitely it initiates the labor, better compression of the spiral arteries, controls hemorrhage, also reduces the entry of thromboblastin in maternal circulation, thereby reduces the risk of DIC and renal cortical necrosis. So I think amniotomy is the way if you are planning a vaginal delivery, and definitely sometimes you need an immediate, sometimes amniotomy fails to control bleeding or fails to arrest the progress, and then we need to take this patient for an operative delivery. So these are the guidelines which are more or less correlating. Everybody has spoken for the same, that vaginal delivery can be offered, and only if there is a compromise or any severe indication, we need to resort to cesarean section. So now the difficulties during cesarean section, I just want to touch, because there may be Curvelius uterus, which is very common during cesarean section. So Dr. Lata or Dr. Achla, you can just talk about it. How do we see a Curvelius uterus? What would be our management points? How
See, if it is a Curvelius uterus, but patient is not bleeding, then you can just let it be. Uterus will contract, but she has to be there in OT, and you have to keep a very, very close watch on her. Because it is not always that if the uterus is Curvelius, you have to do something. But if she's bleeding, then we proceed with whatever are the procedures for our atonic PPH, the stepwise devascularization and sandwich technique. And
I would also add one thing here. So we always want the uterus to contract, and we know that in abruption this may be a problem. So as we are doing section, we always ask anesthetist to, because we are going to deliver the baby fast, start oxytocin also, so that also will help in contracting the uterus. So that will help. I mean, just after you start, not before you start. Just as you're delivering the baby. Yeah.
Basically, coiler uterus, you're not supposed to, unless it is, bleeding too much.
Yeah, that's what. But we are telling just after
Curvelius
delivery.
uterus, the take-home message should be that Curvelius uterus is not an indication for hysterectomy.
For a hysterectomy, otherwise everybody gets, the youngsters, they get panic, and sometimes they can go for a.
And majority of the times, Curvelius uterus actually we didn't see PPH.
99%. I don't think I have seen many of these cochlear uteruses in the institute, but we have not touched it.
Yes,
and
after
it develops the recirculation, and then it becomes.
They become okay.
Absolutely.
So the message is very clear that we often see Curvelius uterus, and we really need to not do anything. If you see something abnormal, you can take a photograph of it if you feel, for your reference. But leave the uterus the way it is, I think.
And Komal, that message should go. Take a photograph and show to everybody. Look, I didn't do anything.
And then monitor the patient. I think this is very important, and not to do anything. And this is just an algorithm to manage.
Dr. Komal, I would like to add one thing. See, many a times we wait for coagulation profile. It may take some time. And, when there is a tense abdomen and, ultrasound, whatever said, and we may not be able to estimate the correct amount of clots. So sometimes it's better we have seen patients developing hematuria and all. Better to start blood and FFPs even on clinical distance, so that we don't wait for a long time and lose patients on that. So we should be like have very low threshold for
I think FFP in these cases. For FFP in abruption, you should have a
large amount of clot. Yes, FFP is indicated because you see a large amount of clot. You know, a lot of clotting factors are already used up. So when you see a more amount of clots, it becomes a clinical indication to give blood products rather than waiting for the laboratory result. I also do it in an abruption. It is always that we start giving FFP because we know that we are going to give more than 1 or 2 blood. So 2 blood to 2 FFP. So that is how we cross match. We ask for 4, we give 2 introp, and then we continue. So I think clinical judgment also is very important.
Very important.
Because a lot of clotting factors are used.
And one more point which I would like to point out is that normally
in abruptio placentae, maternal resuscitation and expedite of delivery, these are the 2 key points which helps to the patients to prevent the maternal mortality also and morbidity also. So in that we have to highlight on that, position, oxygenation, wide bore needles, judicious use of the blood and blood products, and the coagulation cascade. If it is possible, they can do even many labs. I think we are in the institute, so we get PT, APTT also, but a simple BT, CT, PT is also very important. It will give the idea about that. And then if she is going into a DIC, then better it is a disciplinary approach has to be there. Otherwise, what happens, we will wait till she gets hematuria, bleeding, profuse bleeding, and also rightly pointed out by Dr. Lata is that it has to be in a hand in hand. It should not be like that. Now, first I will deliver and then I'll give the FFP and all. So time is very important in that.
Last comment by Dr. Nivedita, then we can move to the next case.
Yeah, sorry. I just wanted to point out that normally most obstetricians underestimate the amount of blood loss in abruption placenta. And then because we get a lot of these cases of renal failure because they've underestimated blood loss. Placenta previa, they see huge amount of bleeding, it's fine. But with abruption, because it's a clot, so please do not underestimate the amount of blood loss and give blood adequately. There's a good algorithm about fetal demise, this much amount, fetal jeopardy, this amount. So please follow that and correct blood accordingly.
Yes, and also in post-op, closely follow the patient for, renal shutdown. Because sometimes you think you've done everything and then you later on realize that you've not looked at the output. So though, of course, in the algorithm, we say we will look half-hourly, but everybody must be aware that renal shutdown is very common after abruption.
Absolutely.
Yes, because that is the first organ which will get affected. So we need to see that renal perfusion is not affected. That is our primary aim. So I think a lovely discussion about abruption, and now Dr. Niranjan Chavan can take the second case. So over to you, Dr. Niranjan Chavan.
Hello. Hi. No, I had a phone call. Very interesting discussion going on. And I really thank all of the panelists who are esteemed faculty members, renowned professors, renowned private practitioners to join today. Thank you. Welcome all. So we move on to the next case. This is 8 months amenorrhea, 32-year-old second gravida. She comes with bleeding, profuse PV. She's not registered. And she gives history of previous 2 history of episodes of antepartum hemorrhage, and she has 1 child of 5 years old where LSE was done for fetal distress. Can I have the next slide, please? So on examination, you can find her that she has hypotension, tachycardia, pallor, and the uterus is 32 weeks with oblique lie. Relaxed FHS is also having tachycardia, and there is a fresh bout of bleeding. As such, in such situations, people are tempted to go ahead and do a PV, but you should not do a PV. And I'm sure all of you will agree with me that with an experience of more than 20, 25 to 30 years, all of you would avoid to do a PV. And then we did a bedside ultrasound, which showed that the placenta was completely covering os. And she's bleeding in hypotension, and there is, such patient has come to your nursing home where there is no ICU backup. So of course, if you are in such a situation, how would you manage her and stabilize and transfer, or would you like to, Dr. Achila Batra, can I have your opinion on this?
Yeah, this patient is definitely has had a massive obstetric hemorrhage because we can see a shock index is very, very high. And so what we need to do is that just resuscitate her and transfer her to a center which has all the facilities, multi-specialty hospital. It should not be to a small hospital also. And what you can do is just immediately catheterize, start IV fluid, arrange blood. While you're waiting for transfers, if you can get blood, transfer blood, otherwise she needs to be immediately.
What you need to do is stabilize, means you need to put an IV line, which is a 16 number angiocath. A large bore needle has to be put in both the IV hands, and you need to transfuse her Hemaxil, give her oxygen, give her head load.
Hemaxil will come later. One should not give Hemaxil immediately. It should come only after
colloids
giving.
immediately.
You should not give colloid immediately.
Yes. So
when you can give, non-reg, but not colloid.
See, it depends upon what situation and what the blood products you are having.
No, colloid should not be given as an initial replacement. There has to be crystalloid.
Crystalloids and blood products.
Yeah.
Yes. Now, if I may continue my management, and your inputs also are really very important in such situation. You have to understand that what are you dealing with? Is it's something like a placenta previa or an accidental hemorrhage, or it's a placenta spectrum disorder?
So
what would you
So we always think the worst when we actually are planning for a C-section, because obviously this is a placenta previa, but it could be an adherent placenta because she has not been investigated before. However, if I have done a bedside ultrasound and confirmed that there is a placenta is low lying, I should also examine at that time, put in the color flow to see if there is any color flow entering into the myometrium, or if it is going into the placenta accreta spectrum. So once I have done that, once I've taken that diagnosis, however, at the back of my mind, we should always plan that this could be a case of placenta accreta. So the planning for the C-section should be the one that the OT should have a good team, the anesthetist, senior obstetricians. You should have availability of blood and blood products, and you should have the backup of an intensive care unit before you take this patient up for C-section. Two, a consent not only for the high risk, a consent for hysterectomy, and sometimes even a consent for death on the OT table.
Death on table.
Yeah.
It is very. Yes, Dr. Lata.
One more thing we should always remember is we don't know, like previous section, as she said, we take consent for hysterectomy. Many times we have seen even infiltration into the bladder and all those things. So we should even take, consent that we may have to remove some part of the bladder and repair it and all those things. So all this has to be done pretty fast, especially when the patient is bleeding. Had this patient not come with bleeding, we had lot of time to discuss with the patients, and so
Means we could have in our and we get time to post her electrically, etc. But unfortunately,
this patient,
we get such patients in our tertiary center where I work at Sion Hospital, and they are suddenly coming at our doorstep, where sometimes they are not even accompanied by the doctor or a nurse or an accompaniment. So in such cases, you have to have in the back of your mind that the worst scenario, Dr. Lata has said, that you need to have all these consents and explanation to the patient, as Dr. Nivedita has said. Now coming to cesarean section, what would you do? Classical or lower uterine segment?
It's a central placenta, so lower uterine segment will be accessible. It's not that it is,
But you should
Unless,
try to go
yeah.
above the placenta.
Yes,
You can see the
yes.
blood vessels out there. Try
Yeah,
to go
we can
above the blood
ligate it.
vessels.
Yeah.
Yeah.
If
Yeah,
necessary, we'll
before
ligate it.
cutting the peritoneum, the bladder should be retracted as much as low down as possible. Because in case you need to do a hysterectomy, the bladder may not come in the way. So
Well,
that is a thing
otherwise,
which
yeah, you're right.
One,
But I mean, we can even retract it later in case she's going in
So,
for hysterectomy,
I-
but
I
delivery of
think
the
you should
baby.
take out the
one
baby.
at a time.
and
I
then-
know everyone wants to speak, but one at a time because I
Yes,
can
sorry.
see who is speaking and I am,
Sorry, sorry, sir.
you know, in such a situation wherein when you are sitting in live, I can understand who is speaking what. So I just heard Dr. Alpana speaking, then I heard Dr. Nivedita, before that Dr. Achala, and I'm
Sorry.
very sure Dr. Rajeshri is also going to speak.
We see we are getting all these questions. One is the very good thing that ki stabilize and you have to shift to the nearest center. That what I mean to say in that.
Yes.
And
Now,
the second important thing is
Madam,
that
now
when
she
you
is in the operation theater.
Yes. One
Placenta
is
previa
that
diagnosed, stabilization has been done. So now
careful. There are 2-3 things we have to be. The one is the proper delivery of the baby. Either you should go through the placenta and first try to deliver it properly. Second thing is that the dissection of the bladder, it should be very important one. And third important thing is that adherency of the placenta. So she might bleed it from that side. Grade 5 or table death consent we have taken for that, but you can add to it that internal iliac ligation also. You know, if it is possible, somebody is trained in that, then they can go for that part rather than going into the obstetric hysterectomy for that. But the decision has to be very quick one, whether this patient will be, with the salvageable of the uterus, and she will have, she should not succumb to the procedure. So that decision has to be taken on time. So if
Madam, I would request everyone to be concise. I know that we are in a very bad situation. This can happen to anyone, and we will go ahead. It will be, whether to do for internal iliac first and then deliver the baby. It's not possible. You will have to deliver the baby and then
delivery of the baby is the first.
Yes, and then decide whether to after removal of the placenta, I mean, how much time, all these things will have to be decided on table. But it's very important that when it is a placenta previa, we put our fingers and we try to remove everything. Some of the cotyledon, some of the pieces of placenta are still adherent, and she is still bleeding profusely. And I remember also that during my days of residency as a lecturer, when I used to be on call, or now also when as a professor we are called in such dire situations. Of course, now I got 2 associate professors and 2 assistant professors. But it is very important that whether you would like to start suturing the bed or would you like to go ahead with a hysterectomy?
Dr. Niranjan, you'll have to ask somebody, otherwise all of us will speak.
Yeah, true.
So I was interested to hear from Dr. Kiran Sonalkar or Galaxy, Madam Galaxy is there, or Dr. Lavanya. I don't know who is this Galaxy. Yes.
It's depend upon the condition, in-drop condition. If it is totally adherent and going to bladder or adjacent organ, you have to proceed for hysterectomy as soon as possible. And it's depend upon the amount of bleeding and hemodynamic condition of patient to do stepwise ligation or hysterectomy.
Okay, so you would prefer to go ahead with a hysterectomy, Dr. Lavanya, madam? What would you like to do?
Whether
Can you
the,
please unmute?
yeah, I would like to assess whether the placenta adherence, what grade is it, and how much bleeding is the ongoing loss.
Bleeding is
And
massive, madam. She has gone in hypotension. Patient anesthetists are pumping blood.
and then along with activating the massive
by
transfusion,
Dr. Achala.
go ahead with peripartum hysterectomy.
Okay. Anybody would like to go for an internal iliac ligation first and then hysterectomy?
Yeah.
Dr. Achala, madam.
अभी इतना बड़ा लेक्चर हो गया इंटरनल आइलियक लाइगेशन का. So
not in an unstable patient, because if you will, like you said, you are in a pool of blood, patient is in collapse. In that case, it's better to take a decision of hysterectomy earlier than later.
So please understand that in spite of all
So
this,
here I would like to state what we do is that we pack the endometrial bed. We pack it with tetras or sponges, whatever you call it. We keep packing it 3, 4, whatever it is, and
put pressure
put pressure on the placental bed, and then we start systemic devascularization. Uterine artery first. Devascularize the uterine artery. Devascularize the. When you devascularize the uterine artery, put pressure for quite some time. Sometimes the blood loss decreases, and I can actually see from which part of the endometrial bed she's bleeding. So if you put the Babcock's artery forceps and reflect the lower part of the incision, if you can identify those areas of bleeders, you can actually stitch those areas of bleeder with either number 0 catgut or even 20 catgut, or even 30 vicryl rapid. The 30 vicryl, it heals beautifully, and the uterus can be saved. However, if you feel that at that time that you are unable to do anything else, then maybe you can go in for a hysterectomy, but conservative surgeries can be done and it has helped.
So sometimes even vascular clamps have been used so as to, prevent a hysterectomy, especially. Yeah.
Even if you don't have an aortic clamp,
at least give a compression.
The aorta. If you just press the aorta manually, but that
yes, I have done that. I have done that in last patient.
Depends
only.
upon the condition of the patient. Like you have to see the condition of the patient. If there is such a condition that you want to do conservative surgery, then you can, press the aorta and try everything else because
so you have
but
to
if he is profusely bleeding and collapse, then I wouldn't like to do all that. I would rather, go in for hysterectomy.
I think this patient has become, hypotensive and she was bleeding profusely. So one can go ahead with the obstetric hysterectomy and then you can. But
I think the majority of you all are saying for obstetric hysterectomy. So we will proceed now with obstetric hysterectomy. That would be the general whole consensus. Well, of course, when you have a placenta accreta, then you have diagnosed it on ultrasound, you have diagnosed it on MRI facilities available in a tertiary section, and then we need to go ahead and perform a preterm cesarean hysterectomy, and all this consent has to be taken. This is what is also been published in one of the journal by Visconti et al. And conservative approach also can be considered in such cases of women with a strong desire of future pregnancy. So this is a European study, but of course, most of these cases of placenta accreta, percreta, or placenta previa, they are usually 3rd or 4th gravida. So this situation is not available in India. Now,
no, sir. Dr. Niranjan, we have done a study in Safdarjung Hospital where we have done about 20, yes, maybe more, where we've left the placenta in situ and, it's
Madam,
not that
here we will come. We are coming to that. What is the role of medical management for placenta accreta? Medical management. Anyone?
Yes, madam.
Only continue the 25 cases of Safdarjung.
Achha, madam, you can continue.
If it is a totally adherent placenta, there is no sign of separation and the woman is not bleeding at that time, you can keep the placenta in situ and follow it up with injection methotrexate.
Yes, so this is also
I disagree because methotrexate has no role in placenta accreta. In fact, a patient who is likely to go in for maybe later on when you're leaving the placenta and she can go in for any coagulation failure, it is better not to give methotrexate because it's not been found to be of any help in placenta, when you've left the placenta.
Madam, but we have given patients here in our...
We have also given, but the evidence says that...
the recommendations say that methotrexate is of no use because methotrexate is only of use in an actively dividing tissue. True.
Yeah.
Plus, methotrexate,
when the woman it has to be a live tissue only, madam.
Yeah, but however, here I would like to say, I have personally used methotrexate and I've found that after 3 to 4 days, the placenta actually separates and comes out.
Any personal experiences, others?
Yes.
Can I say something?
Yes, Dr. Lata from Jipmar, Pondicherry.
Okay. This is not an emergency situation again. we have done embolization of the uterine arteries before taking up. We used to put a catheter,
Can we
then
have the
do the
next
section,
slide?
and then we did the embolization. And even if you have to do hysterectomy, it's been very perfect. So that is my experience, but I don't have any experience on methotrexate because 1 or 2 cases we have given and patient came back with sepsis.
We used to give, but after the evidence came that it can be of more harm than use, we stopped giving methotrexate now.
Okay, so we have embolization, we have methotrexate. Methotrexate is outdated.
Embolization is indated.
Embolization is
I think embolization, if you have already diagnosed percreta or morbidly adherent placenta and we have an interventional radiologist, then best thing is that you have to go for the embolization. What we are also doing, because in our institute, we have that. Previously, in a couple of cases, we have been used as a methotrexate, but now we won't use much of that. But basically, embolization, it helps for the percreta.
Even if you don't have, if you've left the placenta, you want to do an interval hysterectomy, then also you can send the patient for embolization and then do a hysterectomy after 4 weeks. Yeah.
So embolization is very good.
So we are all getting responses from North India, from Western India, from South India, from Eastern India, Central India. All are saying that yes, this would be a better option. Take home message and
availability has to be there,
availability has to be there. Affordability
has to be there.
Luckily, not in government setup.
No, we have a government time.
We have got
No, that's what I'm saying. Luckily,
interventional
I'm talking about economy is not a problem in government setup. I'm not saying not.
Even in subsidiary hospital, we have embolization, not emergency, but
ma'am, I'm not talking about availability. I'm talking about affordability. That is not a problem.
Affordability also. We have schemes also and donated people also. So,
Madam, we have donations. Salman Khan donates graciously in a Sion.
And even Mahatma Phule Yojana.
This Pradhan Mantri Yojana, there is Rajiv Gandhi name.
Rajiv Gandhi Yojana. JSY, JSSK
also.
And
all there, we are using it routinely.
And we have Sunday Friends, which are there for last 40 years with us. They always give. The medical social welfare department is there. There is a poor box fund which goes in crores. So all these things are there, and this is now some article which is there. Now, what is triple P procedure? Dr. Nivedita?
Yes, back and pray. That is one. And then 2 is that you plan. Then the second thing is that is one part of triple P. The other one is for the placenta accreta syndrome. You plan, you have pelvic devascularization, and the third is in case of placental non-separation about dissection of the myometrium. So these are the 3 P's on this side. So you have to plan for the uterine incision. Where will you give the uterine incision? The uterine incision should always be, as we know, above the where the placenta starts, just above that, so that you can do not injure the placenta while entry. Then after you deliver the baby, you start devascularization even before you think of removing the placenta. So you just wait for the you do the devascularization. After the devascularization, since the placenta is still there and it is if it is not separating, then or if it is stuck to the then if it is stuck to the myometrium, then you might even have to remove a part of the myometrium and repair it. So this is the third P, that is in placental non-separation of removal of the myometrium and repairing it. So this is in case you want to leave the uterus behind. Otherwise, the commonest thing what we do is we take a consent and we do the hysterectomy.
Dr. Chavan, we have done one study where 50 cases of the placenta previa and scarred uterus and unscarred uterus. So we compared in that how it behaves in that. So there is more adherency with the previous cesarean section scar and more morbidity in that. And you can anticipate always in such cases, and then you can plan the things in that. So I published that study in an international journal. So.
Madam,
if there is a small bit of uterus where the placenta is adherent, then it is feasible to remove that part. But if it is the whole of the placenta
anybody has,
then you can't.
Yeah, what?
Any experience on resection of myometrium? Any of the panelists has done?
I have done, small bit of placenta was adherent. not a very huge bit. So I did resect that and restitch the uterus, and it was, of course, I also did ligation of that patient. And
but the thing is that if it is not bleeding, then you can might leave the placenta like that with for the
then you can leave it. Yeah.
If it is bleeding, then definitely you can stitch it out the part of the things and you can take it. But piecemeal extraction of the placenta gives
not
more
recommended.
bleeding. So
Yeah,
that
it's not recommended. Not recommended. Another thing is that if you are like the depending upon which part of the placenta is adherent. Now, if it is usually adherent in the absolutely the lower segment, their resection of the myometrium is very difficult because there's hardly any myometrium there. So it's it's impossible to do any resection out there. However, if it is that in the upper part, then it is easier to resect the myometrium and stitch it. It's like a myomectomy.
And for the beginners, I think one should tell that they have to see for this, resection of the myometrium. Otherwise, that resected myometrium will bleed and open the sinuses. So it is on table expertise decision to go for the myometrial resection. That is what I would like to say.
I think perfect.
Otherwise, they will listen and they will cut it off the placenta and myometrium, and it will start oozing, and patient will end up into obstetric hysterectomy.
No, it is just a study coming, I think, from the west side, where they are having publishing a lot of cases of segmental resection, but definitely it is what is the condition of patient, what facility, what you are having, and you really don't want to explore this patient again. That is the most important thing. And your first surgery should be the perfect one.
And one should understand the cleavage between the placental and the myometrium also, because sometimes the placental tissue and the myometrial tissue, so otherwise chopping out. So sometimes if it is more adherent, it will come to the cirrhosis also.
We require really great amount of
expertise. And if they have any good ultrasound or MRI, that can give rise to the depth of the infiltration of the placenta into the myometrium. That is also very important. I think on table, one has to.
When we say partial resection, then we are removing the part which is adherent to myometrium along with placenta. The plane doesn't really matter, but it has to be small, which our experience is only with very small parts.
You need to repair it also back, so it needs to be really small.
It is very important.
And, the idea was just we require really more amount of Indian studies on this before we.
And Komal, don't touch the placenta who is not bleeding, unnecessary. That is very important. I mean, this procedure, where to do, iske bajay where not to do. That is very important.
Okay, now can we, I think we have discussed this also. Yeah. So Dr. Achala Batra madam, after Mumbai AICOG, we will be coming to Delhi AICOG, where you will be
hopefully
explaining all the details in depth, and we will be having all professors there, guiding the delegates, and we will share the knowledge. So thank you. And now I hand over the mic to Dr. Komal.
Thank you. And I think the major part of our placenta is actually over, but just touching upon the most commonest case, this is 25-year-old, gravida 7, para 4, living 4. She comes for delivery. She comes and rapidly delivers, and without any difficulty, but placenta is retained. So retained placenta, another nightmare, and patient bleeding. So now what? How do we actually prevent? I think somebody can just explain, because I think benefit of audience. The third stage is most important.
Placenta can be of two types. One is separated and retained, or it is not separated. So one, you have to be very particular. One, you have to be bleeding. Then separated and retained, or not separated and retained. So you categorize according to that. Now, if it is separated and retained, all you have to do is a controlled contraction with ensuring that the uterus is contracted by uterotonics. If it is, sometimes the os gets closed, so you will require some amount of anesthesia to ensure that the os is dilated again with the anesthetics, and you can remove the placenta easily. Now, if it is not separated and retained, then you have to do manual removal of the placenta. If you're sure that she does not have, she's done a vaginal delivery, no previous C-section, you've done a previous ultrasound, no adherence, then you can do manual separation of the placenta, manual removal of the placenta, or MRP. And that should be usually what we tell our staff is that please ensure that it is done by the senior doctor. Do not try to handle the placenta. Do not remove it piecemeal. There's a proper technique, and we all know that you put in the identify the cord, see which side is adherent, insert that hand completely, shear it off until by shearing movement keep going up till you get to the fundus, then hold the whole placenta and bring it out slowly while keeping the uterus up. So that is how manual removal is done. Ensure that the uterotonics are in place and the uterotonics are there. After that, you might have to do massaging of the uterus so that the uterus remains contracted.
I want to add one thing is that don't give the fundal pressure, with
absolutely
separated. Otherwise, it may lead to inversion of the uterus.
Yes,
So
I
that has to
would
be
like
very
to add, when you are going in for a MRP, be ready for anything. So without arranging blood, don't try.
Don't try.
Because you don't know what you will be encountering. So always arrange blood.
You should always do it in the operation theater so that you have a backup, because if suddenly the patient collapses, at least there should be someone at the head end to manage the patient. Should always have full backups.
See, another thing,
I think
before just trying the manual removal, because placenta is not delivered within 15 minutes, the most important thing is,
I think at least we should wait for at least half an hour.
Start oxytocin, and majority of the time they'll expel, especially if it's not
Yes,
adherent. Okay, if that doesn't happen, we can take her to OT, and then of course oxytocin.
Actually, I was waiting for asking that. Okay, what is your next step? What about giving more oxytocin? But I think Nivedita went till MRP.
Yes.
So, Komal, so whenever the placenta doesn't deliver, don't get panic. Wait for some time. Give oxytocin. Let it separate, because sometimes uterine inertia can lead to, to take a time for separation and even delivery of these things. But if it doesn't happen and patient is bleeding profusely, go for a MRP with operation theater preferably. One should not do in a labor ward, because most of the
never
labor ward and pulling the cord and all. So it should not be like that.
We have even tried giving oxytocin, in 50 cc of saline in the
many of them
sometimes. But in an adherent placenta, it doesn't help, because suddenly one day I got a call, placenta is not coming. I went, the placenta with inversion was done. I mean, so with young people, it can be, because sometimes the fundal pressure, there is a habit of giving fundal pressure. So non-separated placentas, one should not give the pressure from above downwards. It has to be suprapubic pressure with in a upward direction, and then with control cord traction, we can see to that. Then second important thing is that there should not be, sometimes you will get a velamentous insertion of the umbilical cord, and that cord, while pulling that cord, it can get break. Or third is in cases of the vasa previa also. Sometimes, so these are the placental abnormalities, and in that, then you have to be very careful in that, because the cord has been severed and patient will bleed profusely. Then ship the patient in operation theater, and then with the senior expertise, you can do a manual removal of the placenta.
Dr. Komal, as you said about active management of third stage, the moment placenta is delivered, I think majority don't have the habit of examining the placenta. That's where problems come. So that has to be emphasized. Though we know that they should be doing, but it is not being done many a time. So I think that is one reason why retained placenta is missed.
Always one should examine placenta.
Any lobe or anything of placenta can be remaining. So you need to completeness. So MRP, I think everybody knows the procedure has been said. You put I think beautifully described, and examination of placenta, very, very important. We need to examine both the sides with any cotyledon or anything remaining. So this is very, very important. And the same now, if you're taken her for an MRP and if the entire placenta is not coming out, and what will you do? There are two scenarios. Placenta full has not come out. Patient is not actively bleeding. What do we do? And if she's actively bleeding, so first not actively bleeding. Let's start with Dr. Lata. What will you do?
Leave the placenta.
It's I mean, we should try and remove as much as possible, but if it is not there, I mean, the situation is like it, the placenta and leave, and look for, I mean, at that time, maybe methotrexate, as it was discussed already, because we have not opened, it may help and she may come out, but majority of them land up in secondary postpartum hemorrhage, and they require uterine artery, I mean, what is it, embolization and things like that. So try to remove even if it is not bleeding. That's what is the thing, because whatever I felt when we have retained the placenta, they have come back with sepsis. That is are this thing. So try and retain. I mean, remove it
Sometimes
as
we
much as
could
possible.
even insert a
Yeah,
suction,
even
this thing
suction
curettage, and
and-
just go beyond the line of separation and try to do a suction if you can get out the placenta, the remnants through that suction. Yes.
No, could I just, I could like to clear, find, because this is slightly confusing for me. You are trying to do MRP, and in MRP, you're not going to pull out before you find that the whole plane hasn't cured up.
Separate.
So, I mean, it cannot be that you're doing MRP and the entire placenta does not come out.
Yeah. No, the whole point is it is adherent. So what will you do?
Focal accreta
If the total placenta is retained and she is not actively bleeding, then you just wait for some time. You wait for some time.
Even I agree with her. Don't touch it until,
No, I think the whole question is you have taken for MRP, and that means you have waited at least for 2 hours or 3 hours, given oxytocin. Then what will you do? It's not
Then
that
what you will
immediately.
do? No, I think the question is you have not gone. A junior has gone. She has tried.
Then we will help, ma'am. But the question is, I think
some, and then she
beyond.
calls you that some days it is inside. I think
then you have to intervene. Once the placenta has touched, you cannot leave that placenta like that. When the junior has attempted, then as a senior, you have to complete the procedure. That is all moral.
If
But if she has not touched and if it is not bleeding, then you have a chance of observing it.
Yes.
Or
Then you have to see
embolization, whatever you have set up.
if she's not bleeding,
your take on
then
it?
to evaluate for Akrita.
Yes.
If she's bleeding, you have to do immediately.
You have to do anything.
Then you have to evaluate later for Akrita, and if she's not Akrita, maybe she will expel.
If she is bleeding, the whole this thing is that it is not percrita because it's accreta and it will come out. The whole problem is when she's not bleeding and it is adherent. And that we can, and which we have not diagnosed earlier.
Dr.
That will be a
Lata,
problem. Yes.
when a junior removes a partially adherent placenta, they remove the part which is not adherent.
That is true.
Uterus
That
doesn't
is, no, I'm not
patient
talking
does
about
bleed.
that. I'm talking about a placenta which they have tried, not able to remove, and even if they tried manual removal, it's not. That means it's
Komal
a
has put in a
percrita.
question if the entire placenta doesn't come out.
Yes, exactly.
That means some bit has come out.
Yes.
So,
certainly scenarios wherein you see and
This
the
is a very common
placenta is not
situation.
actively bleeding. I think Dr. Lata had some restrictions of keeping it because of the infection. I think infection is the only thing which is most important because at times after delivery, placenta is not a very live tissue. And I have also last case it was discussed. I have also had couple of cases wherein but the patient was bleeding. We have given methotrexate also. It has worked. But at times, a normal delivery case where the placenta had not come out completely, the part was removed by the resident, and patient was stable, and we kept the placenta. And the only thing what we debated was the infection, and we saw that the patient received good antibiotics and everything. And by the end of some 8th or 9th day, she passed the entire placenta and she went home. She was referred from some private practitioner to me. And he really was very panicky. She had delivered outside and she came to a tertiary center and we treated her very conservatively. And from that time, I have left few of this placenta and they have come out. But even we have tried methotrexate also at some places. Sometimes some patient having bleeding. We want to do all our best. So there are both studies which we have done. I just wanted to take off Dr. Kiran also because he must be also encountering that retained placenta is a very common condition. So what is your take when the patient is bleeding? How will you manage it? What are the role of oxytocin? I have not added the PPH part much in this PPT discussion because Dr. Sheila Mane has spoken so much about it that all falls good for this case also. So Dr. Kiran, I just want your take.
If there is a tissue of placenta remaining and patient is bleeding, then you have to do PPH drill. To stop bleeding is our priority. So you can do by suctioning PPH cannula. If it is not working, then you have to then open the abdomen and you have to do devascularization of uterus. And so you have to prevent all the measure to prevent a blood loss.
Yeah. So I think yes. So I think rightly you have said that we try first of all everything what we can try locally, and if not, we need to prepare even to open. And we need to be very fast and act fast when there is and sometimes after removal of placenta also there is a bleeding. So that comes the role of suction, that cannula or tamponade, whichever way you can use it.
I have reservations about tamponade because the whole idea is we want uterus to contract. Tamponade is okay if you're going to go to theater and do a surgical intervention, but otherwise, thanks to the suction cannula, it's
I know
really
at your
working.
side, everybody is using suction cannula. We still have to use it, but definitely.
But it is definitely helping, no doubt about it. It's like
So
it's dramatic.
Making the uterus to stay in contracted state
Yes.
is very, very important post.
No, I would like to say that I have even used tamponade in placenta previous, where they've been bleeding from the uterine bed, and it's not that the only thing is that the tamponade has to be slightly low down. Here, the tamponade has to be slightly low down, and I've managed to conserve the uterus in this. I have used tamponades in. It's not that the tamponade prevents the uterus from contraction. At that time, it is a not a very high. It's a high volume, low pressure tamponade. So the myometrium does start contracting over the even over the balloon, and you can understand because slowly the balloon, you can find that the balloon is slowly coming out. So and then it can be the bleeding gets controlled beautifully. The SR cannula is fantastic. I don't deny it. It is fantastic. It causes a very good contraction and retraction of the uterus, not just contraction. It causes retraction of the uterus, so that is extremely important. But tamponade has been quite effective also.
Yes. So
now
I think,
we even have a Ilavi balloon, which will, the fluid will come out of the balloon as the uterus contracts.
It's the same
And lastly, Komal, if suppose, placenta percreta is there, even after doing of any, OH and all, there is a role of internal iliac ligation because the placental bed, the stump, and all the, blood vessels, they do bleeds or the oozes lot of things. Then you can do a bilateral internal iliac ligation in the cases of the morbidly adherent bleeding profusely placenta previa when we open it, or when we are doing cesarean section with such cases in that. So definitely, because I am in the institute last 2 decades, we are doing with the internal iliac ligation. So definitely it has been helped very much. Many cases where there was one case I would like to share that when I opened the rectus, the peritoneum was seeing with adherent with the placental bed and sharing of the vessels. So it was looking like, there is no peritoneum. And the whole placenta was like that, and thin layer of the peritoneum, abnormal big vessels in that. I delivered the baby, it was oozing profusely, and there was no myometrium left in that. Only cervical os was there. That we pulled with the, Alice forceps. We took it out. After that also it was bleeding profusely. Then we ligated bilateral internal iliac ligation, put a drain at both the sides, and after that the patient saved.
Yeah, very rightly you
so
said.
This is because there was no myometrium left. I have published this case also. I'll put it in the group if there, but there was nothing, only os, and it was very difficult also in that. And the whole thing was like, the whole uterus has been like a morbidly adherent placenta only.
Yes, so I think we get all these
cases
unusual
you can
cases.
do the internal iliac ligation.
Yeah, unusual cases, and you need to be prepared for the worst scenario. And I think internal iliac artery ligation, if it's done rightly at right time,
right time. And this has not been picked up on MRI also, because MRI gives the plane of cleavages and the plane of the myometrium and the placental and myometrial junction or penetration, but it doesn't give the
many times we get a double time. We sometimes get an MRI report showing that it is an acrita, and when you open it may not be an acrita, and sometimes so we are getting contrasting.
So for that MRI angiography what should do, but that we don't do that for that.
Don't do that. So anyway, so I think we have managed the patient. I think everybody has shared all the vital points, but we need to continue the care of this woman, even monitor. You have tackled the cases of PPH, all the cases what we discussed. The next 48 hours are going to be really very important. Keep the watch on the tone, the vital parameters, the blood loss, the adequate fluid, the blood transfusion, everything, the urine output which was highlighted, everything, and also maintain a documentation. And I think Dr. Kiran Sonwalkar is from the medical legal committee. I want him to give some points about documentation, how and when we should keep documenting, and how can you give some expert comments on that?
During any case of PPH, you have to documentation is necessary. You have to take all consents with the patient, complication to the death on table, on writing. You have to explain all the procedure, outcome, advantages and disadvantages, and future long-term complications. So you have to take all related concern regarding it. Initially, you have to choose, you have to manage this case or you want to transfer this case. If you are transferring the case, the transferring document also important. And in case of death on table, the most important thing is documentation, counseling, and consent. So these three things are important, and take all related consents. And in case of PPH and emergency, always ask for help, ask for senior gynecologist, ask for senior anesthetist in OT, and call for help. More the people, gynecologists, more the anesthetists, they will help you to handle that cases.
Komal, I would like to share one thing is that we do most of the inquiries of the death reports, and there was one case of placenta previa. She was a highly profile case and blood group was negative. Only 1 point was kept by the obstetrician. And after that, when they opened, there was adherent placenta and that young patient died. After that, there was an inquiry, and about that, the opinion has been asked in that case. So it was very difficult to say that, you know, when we are considering it, it is could be a morbidly adherent placenta, then more amount of the blood should be kept available if the patient comes in a elective. And that was the thing in that. So it was
I think good points. I think very well said by
because they said because what they ask us that, ma'am, if it is a placenta previa, what is the chance of adherency of the placenta? I said there is a chance of adherency of the placenta, and after that also, if suppose that is adherent placenta, how much amount of the blood, as she was negative in that hospital, only 1 point was there, and to get a negative blood group, they have to run everywhere. In that she bled a lot. And they could not survive it.
Taken very well. I think we are a little short of time. We are overshooted our time.
Yes,
So everything, and anybody now, I think vasa previa, anybody has experience. I just don't want to ask and go into it. But anybody has seen a case or anything, we can just go about vasa previa, and we know diagnosing is a key, and cesarean delivery is very, very important, because if it bleeds, it is going to be a catastrophe. So I think everybody, Dr. Achla, Dr. I think Dr. Lavanya is quiet for a very long time. So we can have her inputs.
Yes, ma'am. Madam, personally and honestly speaking, I have not seen a case of vasa previa till now, fortunately. Of course, only theoretical management is what we know, and mapping it properly antenatally. And whenever we have an accessory lobe or an accessory placental lobe, or whenever there is a low-lying placenta, we have to look for, rule out vasa previa antenatally, and do either transvaginal or a transperineal Doppler to see whether there is vasa previa or not, and go ahead with an elective cesarean section so as to have a smooth delivery. Personally, of course, I honestly accept I have not seen a case of placenta previa till now.
See, they are in the institute, so bilobed placenta, battledore insertion, filamentous insertion, and vasa previa. So sometimes we do get that referral cases. So.
Dr. Achla ji, they're at Delhi.
Hello, I haven't, previously diagnosed, but after, fetal distress, after a small amount of bleed, and then we've done a section and then we found, but I haven't seen any, diagnosed on ultrasound and managed.
Yes.
Same here, actually.
So it is very important that we need to diagnose, because if certain cases come, we need to be very rapid, because fetal excansion can occur and there can be high mortality. So we really need to confirm, and these are how we should go about. The recommendation and the guidelines are there. And so this vasa previa is strongly related to adverse fetal outcome and stillbirth and PPH. So it is our interest, and we have discussed all the placental abnormalities. So I think we have done a very good panel discussion. We have just talked about the placental pathology, but the placenta also has PIH and other IUGR and everything, which we have not discussed, because we had multiple discussions on these topics in the previous episode of Trending Ask the Expert series. So we have excluded that, and we have just restricted to the obstetric hemorrhage cases, and vasa previa was one of it. And I think I will end now. If you change the way you look at things, the things you look at change. And we all need to change the perspective when we need to be really vigilant. I think everybody has given such important points, and they have brought out very practical points in seeing we need to foresight complication, we need to act fast. This is very, very important. And with that note, I end with a request to everybody to support me in the upcoming elections of the Vice President. And the voting is from 1st of August to 10th of August. So do vote. Do tell everybody to vote. That is very important. And I thank you all for your patient hearing.
Thank you. Thank you, Komal. It was excellent presentation, excellent discussion. All expertise, they were very good, and it will be very, very much beneficial. And definitely, I think you are such a great academician also, popular also, and I think all our best wishes.
Thank you. Thank you so much.
Best wishes. Now and forever.
Enjoyed the panel.
Yes. Thank you so much. I think everybody had such lovely inputs. So thank you all the esteemed panelists, Dr. Achla Batra, Dr. Lata, Dr. Nivedita, Dr. Lavanya, Dr. Rajeshri Katke, Dr. Kiran Sonwalkar, Dr. Alpana. I think lovely. I think everybody has given such valuable inputs, and the recording will be available. We'll share. You can share it among your society members so that they all can benefit. It was a real great discussion today. And I hand over to Dr. Shreya, if she's there, for the formal vote of thanks.
Thank you.
Thank you, ma'am. I would like to thank all the speakers, all the panelists and moderators, Dr. Komal ma'am, Dr. Niranjan sir, and everybody has given such valuable inputs. I'm sure not just residents and people at the the institute level, but every private practitioner who's heard today's session is going to be beneficial. Me myself, I can tell you that being a private practitioner, it has been really helpful. And especially I have, it's the first time I've seen the internal iliac anatomy so beautifully shown, and I love the idea of having a 3D model, ma'am. Thank you very much for everybody to be present here and give us your time and your inputs. Thank you, Komal ma'am and Niranjan sir, for giving me this opportunity to be here today and be a part of this program.
Thank you so much, Shreya. Thank you, Shield Connect team. Thank you all, and see you soon in the next episode. Bye, bye, everybody.
Bye. Thanks a lot, Dr. Komal, Dr. Niranjan. Thanks a lot. Lovely interaction. Very nice interaction.
Thank
you.
Bye.
Bye, Dr. Komal and Dr. Niranjan and everyone else. Bye.
Thank you, madam. Thank you all.